7, 8, we have 8 members. We want to tell, if there are members in the committee room.
We have people set up.
How are you? Welcome back. I thought of you. I did think of you. I did think of you. I did think of you. The Subcommittee on Health will come to order. Welcome back, everyone. I hope you had a productive August and that you've got some rest with your families and roll up our sleeves and get back to work. The chair now recognizes herself for 5 minutes for an opening statement. Pardon me. And the witnesses, please come to the table. And thank you for each one of you being here. The United States is the most dangerous place in the developed world to deliver a baby. That is a quote and the conclusion of a major investigation by USA Today last year. Each year, about 700 American women die and 50,000 women are severely injured due to complications related to childbirth. If you're a Black woman in the United States, it's even more dangerous to give birth. Black and American Indian and Alaska Native women are 3 to 4 times more likely to die from pregnancy-related causes. This is absolutely unacceptable. And what's more, it's preventable. The CDC estimates that more than 60% of these deaths could be prevented. Our witnesses will instruct us today that there is a clear way to save mothers' lives. We need to make sure that women have high-quality care and coverage before, during, and after their pregnancy. And the 4 bills we're considering today do just that. Congresswoman Kelly's Mama's Act uses standardized data to inform healthcare professionals about the best practices and protocols to manage a mother's care in an emergency, such as when a mother hemorrhages after birth. This data-driven approach was spearheaded in my district at Stanford, California's Maternal Quality Care Collaborative, which has reduced severe health problems from pregnancy-related hemorrhages by 21% to date, and has contributed to reducing the maternal mortality rate in California by a whopping 55%. Representative Engel's Quality Care for Moms and Babies Act also works to improve maternal care through data by using care surveys, quality measures, and perinatal quality collaboratives. Both Congresswoman Kelly's legislation and Congresswoman Presley's Healthy Mommies Act recognize that to truly make progress, women must be able to get medical care when they need it. Women are more likely to die of a pregnancy-related condition in the weeks following birth than during pregnancy or delivery, but many American mothers lack health insurance during that critical postpartum period. Every year, hundreds of thousands of mothers are kicked off Medicaid only 2 months after giving birth. The Mama's Act and the Healthy Mommies Act extend Medicaid for a full year postpartum. These bills make sure the Medicaid safety net is there for women at one of the most vulnerable times in their lives. And this extension makes sense. That's why state legislatures in California, New Jersey, Texas, South Carolina, and Illinois are seriously considering measures to extend Medicaid for 1 year for eligible new mothers. Finally, the Maternal Care Act, introduced by Congresswoman Alma Adams, addresses the insidious way racism kills Black mothers. The bill funds implicit bias training programs for health professionals. As Nina Martin describes in her investigative series, Lost Mothers, African American mothers repeatedly report being devalued and disrespected by medical providers who did not take their medical concerns seriously. I'll conclude as I began. The United States is the most dangerous place in the developed world to deliver a baby. Shame on us. I believe a high maternal death rate is a reflection of how much a society values women. As the first chairwoman of this subcommittee, I think it's time we reverse this by making a healthcare system that better cares for women. I now would like to yield the remainder of my time to Representative Engel, the author of H.R. 1551, the Quality Care for Moms and Babies Act. Oh, he's not here. All right. Well, the chair will now recognize Dr. Burgess, the ranking member of our subcommittee, for 5 minutes for his opening statement.
Thank you, Chairwoman Eshoo. Thanks for the recognition, and I certainly appreciate that our Health Subcommittee is revisiting the issue of maternal mortality. Certainly we addressed this last year when we held the hearing on Jamie Herrera Butler's H.R. 1318, the Preventing Maternal Deaths Act, which was signed into law last December. And whether people realize it or not, I don't know how many people do realize it, unusual for the House of Representatives to pass a standalone bill dealing with maternal mortality, but it did indeed happen in the last Congress. And now we're here today to see if we can build on that success, build on that progress, utilize the data that is going to become available because getting H.R. 1318 across the finish line. By authorizing grants and allowing states to establish maternal mortality review committees, such as the one that Texas established back in 2013, states will be able to clearly identify the causes of maternal mortality and use that data to inform solutions. Given the robust bipartisan discussions that occurred last year, we do want to continue those robust bipartisan discussions. Fortunately today, the bills that we have before us are all on the majority side. Our staffs have spent some time in preparation for this hearing, so it's unfortunate that that could not have been a little more expansive. Dr. Bouchon on this committee and Representative Andre Carson, a member of the majority, introduced a bipartisan bill, H.R. 4215, the Excellence in Maternal Health Act, along with a number of Energy and Commerce members, and I believe that a version of this language could become law and be signed by the President. And we should discuss the merits of such a policy at this hearing. I think it's worthwhile to have a productive dialogue about the ideas put forth in all of the bills before us today, but there certainly are some questions about how implementation would occur and whether the bills would actually make a difference. In my former life, did practice obstetrics and gynecology. Now as a member of Congress, I want you to know that addressing maternal mortality is one of my top priorities. That's why I advocated, along with Representative Herrera Butler last year, for the passage of H.R. 1318. Over the course of this year, I've been carefully looking at the right next step to build on the success we had last year. I've engaged with the Congressional Budget Office on several policy options related to Medicaid coverage of pregnancy, and I'm committed to finding a way to address this issue, but we do need to be tactful and inclusive in this approach. As we move through the discussion of these bills, I have some questions that I would like our witnesses to have in mind. First, what is the Centers for Disease Control and Prevention already doing to aid states process data through maternal mortality review committees? And do these bills we have before us today, are they additive or are they simply duplicative of existing efforts? Secondly, more than 40% of the births in the United States are covered by Medicaid. What tools do states need to address the unique needs of their own Medicaid populations? Thirdly, some states are already submitting 1115 waivers to expand Medicaid coverage for 1 year postpartum without any intervening federal legislation. How would these existing state efforts be impacted by a federal law? And is there any danger of hampering state innovation? Fourthly, how can we support hospitals' existing efforts to coordinate care and maintain access to physicians throughout the delivery? Fifth, are any states employing innovative maternity care models in Medicaid that would be worthy of exploring in a demonstration at a federal level? And then finally, what are the main barriers to women receiving pre- and postnatal care, and what are the best practices that can be deployed to address maternal mortality and severe morbidity? The so-called near misses that occur when someone actually survives but has a very untoward event. Now, I do want to spend a moment and give a special thanks and a special Texas welcome to Dr. David Nelson, the Chief of Obstetrics at Parkland Hospital. Chairwoman, you said, quoting from the USA Today, that the United States is the most dangerous place in the world to have a baby. I would submit that Parkland Hospital is probably the safest place in the world to have a baby, and it's because of the tremendous leadership, the clinical staff, and the dedicated staff of UT Southwestern, and the residents and house officers and the nurses who all provide care to the medically indigent in Dallas County, Texas. So as a former Parkland resident, I'm looking forward to hearing about the practices that your team employs to ensure safe delivery for both mothers and babies in Dallas, but down in Texas. And I yield back my time.
Chair thanks the ranking member for his comments. Let me just add something to them. The committee is hearing 4 bills today, and together they contain all of the provisions from the Senate HELP bill and Representative Bouchon's bill, but they also go beyond those provisions to include extending Medicaid coverage for postpartum women. So I wanted to add that to the conversation. The chair is now pleased to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes for his opening statement.
Thank you, Madam Chair. Today we're examining the often tragic reality of the maternal health system in our nation and a number of policies that could dramatically improve health outcomes for new mothers and their children. Every year, about 700 women die here in the United States from a pregnancy-related condition, and thousands more face severe maternal morbidity. That's simply disgraceful, and when you compare these outcomes to other countries around the world, the United States is near the bottom. We're also the only industrialized country in the world with a rising maternal death rate. In a nation as wealthy as ours, these statistics are simply shocking and inexcusable, but I'm hopeful that we can begin to turn the tide to improve maternal health. The Centers for Disease Control and Prevention estimates that 60% of maternal deaths in the U.S. are preventable, and the legislation that we're discussing today is a strong step forward. Now, a number of the bills that we have today will strengthen prevention efforts that already exist, including policies that follow up on the Preventing Maternal Deaths Act, which was enacted last year. This new law improved data collection and helped to expand maternal mortality review committees to all 50 states. The legislation also authorizes and strengthens the Alliance for Innovation in Maternal Health and Safety, or the AIM program. This program helps physicians and health systems implement evidence-based practices that have been shown to improve patient outcomes when performed in a healthcare setting, but have not yet been implemented nationwide. Maternal mortality and morbidity are problems that affect women throughout our country, but especially in African American and Native American communities, where women are 3 times as likely to die due to pregnancy-related conditions as white women. The bills also offer a number of proposals to reduce health disparities along racial, ethnic, and cultural lines. And we're also going to be looking at ways to improve health coverage for new mothers. According to the CDC, 1/3 of all pregnancy-related deaths occur between 1 week and 1 year postpartum. And while Medicaid and the Children's Health Insurance Program cover more than half of all births in the U.S., coverage for some new mothers ends just 60 days after delivery. That's why I'm glad we'll be reviewing additional proposals to extend that coverage to 1 year after delivery. Extending access to regular physician checkups and other health services could help women and their health care providers detect and treat health issues such as high blood pressure and heart disease, 2 of the most common causes of pregnancy-related deaths, and it's my sincere hope to work with our Republican colleagues to enact a bipartisan proposal to extend this vital health coverage for new mothers. Our witnesses today offer views from diverse backgrounds, and I'm confident that their experiences and expertise will help us all learn more about the problems we're facing and the solutions that will make a real difference. I thank them all for being here, and I also want to recognize the leadership of so many bipartisan members of the House who testified on this important topic at our recent Member Day hearing, including several members of the Congressional Caucus on Maternity Care and the Black Maternal Health Caucus. So I have a couple of minutes left. I'd like to yield that to gentlewoman from Chicago, Ms. Kelly, the author of H.R. 1897, the Mamas Act.
Thank you, Mr. Chair. Chairman Pallone, Chairwoman Eshoo, and Ranking Member Burgess, thank you for allowing me to make this brief opening statement. Like you, I'm shocked by our nation's growing maternal mortality crisis. While losing 700 to 900 new moms each year is devastating, this crisis, like too many others, takes a disproportionate toll on communities of color. Nationwide, Black mothers die 3 to 4 times the rate of white mothers. In my home state of Illinois, that disparity climbs to 6 times. In the state of Washington, American Indians moms die at 8 times the rate of their white counterparts. It is clear that race is playing a role in these deaths. That's why my proposal, the Mama Act, which I will discuss in depth later, includes provisions to ensure cultural competency training to ensure all moms and families are listened to during their childbirth journey. However, this provision will only take us so far. It's imperative that we continue investing in diversifying the provider pipeline. The racial disparities underlying the shocking maternal mortality statistics make it an already tragic situation more tragic. However, these challenges are not insurmountable. Today's hearing and the commitment from this subcommittee give me great hope for a future where all mamas get the chance to be mamas. I thank the chairwoman for the time and appreciate your efforts in addressing the crisis. I yield back.
To thank the gentlewoman for her work on her important legislation. I now would like to recognize the ranking member of the full committee, my friend Mr. Walden, for his 5 minutes for an opening statement.
Thank you, Madam Chair, and thanks for having this very important hearing. I appreciate all the witnesses who are here to share your stories and to comment on the legislation before us. This critical issue of maternal morbidity and mortality, it's an issue that's quite literally a matter of life and death, and for all women across the country. It's a difficult topic. It's one that's close to my heart. Despite massive innovation, healthcare, and advancements in technology, recent reports have indicated that the number of women dying due to pregnancy complications has increased in recent years. The effects of such a tragedy on any family are impossible to comprehend. This hearing builds off the important work of our committee in the last Congress under the leadership of Dr. Burgess and the Health Subcommittee. Last year, as you've heard, the President signed into law H.R. 1318, the Preventing Maternal Deaths Act. This important law, led by Representatives Jamie Herrera Butler of Washington State and Diana DeGette of Colorado, seeks to improve data collection, reporting around maternal mortality, and develop systems at the local, state, and national levels in order to better understand the burden of maternal complications. These efforts include identifying the reasons for disparity in maternal care, health risks that contribute to maternal mortality, and clinical practices that would improve health outcomes for moms and babies. We've continued to lead the way this Congress as well, and on a bipartisan basis, I would add, sending letters earlier this year to 6 Health and Human Service agencies where we asked for the latest information on what they're doing to combat maternal mortality. I hope we finish the briefings requested in those letters very soon. Unfortunately, I do have to say I'm dismayed at the way that this legislative hearing today came together. For an issue that's absolutely bipartisan, I'm just disappointed the majority would not allow consideration of Dr. Bouchon's bill, H.R. 4215, the Excellence in Maternal Health Act. It's a bipartisan bill. It's led by Dr. Bouchon, who serves it serves as the House companion to the maternal mortality provisions in Senator Alexander and Senator Murray's bipartisan Senate legislation, Lowering Health Care Costs Act. So I strongly support the bipartisan language in this bill as it demonstrates our commitment to further addressing maternal mortality, just as we did in a bipartisan way last Congress. The bill authorizes grants to identify, develop, and disseminate maternal health quality best practices, supports training at health profession schools to reduce and prevent discrimination and implicit biases, enhances federal efforts to establish or support perinatal quality collaboratives, and authorizes grants for establishing and/or operating innovative evidence-informed programs that deliver integrated services to pregnant and postpartum women. The language in this bill passed the United States Senate Committee on Health, Education, Labor, and Pensions as part of Senator Alexander and Senator Murray's bipartisan package. And so I truly don't understand why we wouldn't have had that on the docket today for consideration as well. I just hope we will. I hope there'll be another hearing where we can hear from Dr. Bucshon on his legislation. Some of today's bills would expand Medicaid and CHIP coverage for pregnant and postpartum women from 60 days to 1 year. This is a significant policy change, and one, of course, we need to carefully consider before we advance such a policy through the committee. Importantly, several states have already undertaken such initiatives, and we should gain a greater understanding about the state experience as that'll be critical as we move forward. Given the huge impact some of these bills will have on HHS, I'd also note that HHS is not here before us today to discuss what they're already doing to address maternal mortality. We would benefit from hearing from them, nor to provide their thoughts on the incomplete list of bills before us today. Given this absence, I call on the majority to schedule a second legislative hearing before moving to a markup, and I strongly urge the majority to include H.R. 4215 in such a hearing. It is a good faith, bipartisan bill with Senate support that deserves consideration in the House. Despite my concerns about this process, I have no concerns about our distinguished witnesses today and our panel of experts. I want to thank you all again for being here today to talk about the bills before us, to share your stories and your expertise. I know we'll learn much about the landscape of maternal mortality and care and what more we can do to improve the health outcomes in expectant or new mothers across the country. That is a goal we all share. So thank you for being here, and Madam Chair, with that I yield back.
The gentleman yields back. It's always a pleasure to be joined by former members of Congress, and this morning former Congressman Phil Gingrey is with us, so welcome and thank you for being here. I want to remind members that pursuant to committee rules, all members' written opening statements will be made part of the record. I now would like to introduce the witnesses for today's hearing. Beginning with Ms. Wanda Irving, the mother of Shalon Irving. Thank you very much for being here. Your very moving piece in ProPublica. Anyone that has read that, I think you're really not the same person after you read it. So thank you very much for being here today. Dr. Patrice Harris is president of the Board of Trustees of the American Medical Association. Thank you to you for being here. Dr. Elizabeth Howell, director of the Blavnik Family Women's Health Research Institute at the Icahn School of Medicine at Mount Sinai. Welcome to you and thank you. Dr. David Nelson, assistant professor of obstetrics and gynecology at the University of Texas Southwestern Medical Center. Thank you to you for being here. And Ms. Usha Ranji, the Associate Director of Women's Health Policy at the Kaiser Family Foundation. Our thanks to you. We're very grateful because this is as the ranking member of the full committee said, this is a very important hearing, and we look forward to your testimony. So at this time, the chair will recognize each witness for 5 minutes to provide their opening statements. If you're not familiar with the light system, green obviously is go. When you see that the light is turned yellow, you'll have 1 minute remaining, and guess what? When it turns red, your time's up. So I will begin by recognizing the very distinguished Ms. Wanda Irving for your 5 minutes of testimony. You need to turn the mic on. That's it. And get close to it. We don't want to miss a word.
Chairwoman,
and we have some very energetic people outside of our hearing room. So get the microphone even closer so we don't miss a word. Thank you.
Good morning, Chairwoman Eshoo, Ranking Member Burgess, distinguished members of the committee, thank you for the opportunity to address you. New data released from the CDC demonstrates that pregnancy-related deaths for Black women with at least a college degree are 5 times higher than that of a white woman with similar education. Shalon Maureen Irving had a dual-title PhD in sociology and gerontology and a master's of science, both summa cum laude from Purdue University and earned before the age of 25. By 26, she was a college professor at Hofstra University, but decided after watching her older brother, who suffered numerous indignities during treatment for multiple sclerosis, that she wanted to work on the front lines fighting for health equity. She earned a master's of public health from Johns Hopkins, also summa cum laude, and became certified as a health education specialist while being a weekend caregiver for her brother who was then in a wheelchair. She started her public health career as a Kellogg Fellow, working with pregnant women at Healthy Start in Baltimore. From there, she was hired as a consultant to the CDC, working on former First Lady Michelle Obama's Let's Move initiative. She went on to be accepted into the globally renowned Epidemic Intelligence Service and was quickly promoted to lieutenant commander. As a well-respected epidemiologist at the CDC, she made major contributions to several scientific books written by colleagues and wrote various articles published in scientific and medical journals. She was dedicated and committed to racial equality and health equity. On her Twitter profile, Shalon said, "I see inequity wherever it exists, call it by name, and work hard to eliminate it. I vow to create a better earth." She believed in action over words and launched a consulting firm specializing in exclusivity training. This is the picture of Shalon Irving, the professional, but she was so much more than that. She was my only daughter, born between 2 brothers that she idolized. Shalon was every mother's prayer, and the one that few of us are lucky enough to receive. An unexpected pregnancy at 36 only added to the fullness of her life. She was so excited to become a mother. On January 3rd, Shalon underwent a planned C-section and birth to a beautiful baby girl she named Soleil Mina Danielle. Shalon thought Soleil was her greatest accomplishment. The 3 weeks that followed Soleil's birth should have been filled with joy and happiness, but it wasn't. Instead, Shalon's general state of health steadily declined while her blood pressure rose. She experienced leg swelling, decreased urine output, weight gains, and headaches. But despite repeated visits to her healthcare providers during this period, her complaints were not adequately addressed. Shalon suffered cardiac arrest at home on the night of January 24th, 2017, 21 days after the birth of her daughter, and just a few hours after her last trip to her health provider. My beautiful, vibrant, brilliant daughter was officially declared brain dead on Thursday, January 26th. Believe me, there is nothing more heart-wrenching than seeing your child connected to life support. On January 28th, life support was removed after reading her medical directive. The handwritten last line shattered my heart. "Mommy, I will fight hard, but if there's no hope, please let me go." Shalon fought hard. She did what she was supposed to do. It was the medical profession that let her down. She was a 36-year-old woman of color who went to her healthcare workers again and again in distress and was not properly treated. Imagine the many gerontology breakthroughs, epidemiology victories, and social advances that Shalon could have generated. If only her medical providers had listened to her and addressed her cries for help. Shalon's daughter Soleil is transitioning into a little girl. She is 31 months old now, with a smile every bit as brilliant as her mother's. Soleil is fearless and determined like her mother. She constantly amazes me with her rapidly expanding vocabulary, her capacity for learning French, her athleticism as a gymnast, and her love for art and ballet. But there are no words in the English language to adequately portray the pain I feel when Soleil looks up at me and asks, "Where is my mommy, Nana? Why can't I see her?" Or cries, "I want my mommy," while clutching a picture of Shalon. The loss of my daughter has earned me the right to demand the transformation of the healthcare system I ask you, no, I implore you to take 3 points from my words today. Not every maternal mortality is because of lack of insurance, nor access to care, poverty, or lack of education. The dialogue needs to be reframed so it widens the lens to include the insured, those with access, and the educated. Most pregnancy-related deaths can be prevented. According to the latest CDC Morbidity and Mortality Weekly Report, further identification and evaluation of factors contributing to racial and ethnic disparities are crucial to inform and implement prevention strategies that will effectively reduce disparities in pregnancy-related mortality. Quality of care plays a pivotal role in pregnancy-related deaths and associated racial disparities. It is imperative that more aggressive strategies to break down racial bias and prejudice be deployed now. Sending medical folks to cultural sensitivity or implicit bias training is not going to fix the problem without a redesign of medical school curricula. Postpartum care must be redefined and optimized as well. Healthcare professionals must be accountable. The reduction of preventable maternal death among Black women is a national disgrace and has become an urgent national priority. To paraphrase a line from Abraham Lincoln, it is the cause for which my daughter gave her last measure of devotion. Thank you.
Madam Chair.
Thank you, Dr.
Madam Chair, I don't know if I need to ask for a point of personal privilege or what, but I'm going to say something. I'm a member of the Black Maternal Health Caucus, and I care deeply about this issue, and I think it's repugnant that we have to sit here and listen to whatever in the world is going on out there in the hall. These women deserve better. These women that passed away during and after childbirth, this is a very serious hearing. And that, whatever they're celebrating or complaining about out there in the hall, the Capitol Hill Police need to put a stop to it. If you could ask them to do that, I'd appreciate it. I yield back.
I thank the gentleman. Thank you, Ms. Irving, for your, this is the first step to the promise that you're asking us to keep. Thank you for being here today. Dr. Patrice Harris, you're recognized for your 5 minutes.
Good morning, Chairwoman Eshoo, Ranking Member Burgess, and committee members. The American Medical Association commends you for holding today's legislative hearing. My name is Dr. Patrice Harris, and I'm president of the AMA. I am a practicing child and adolescent psychiatrist from Atlanta, and I'm an adjunct faculty at the Emory University School of Medicine and the Morehouse School of Medicine, and I thank you for the opportunity to testify. The data on maternal mortality in the U.S. are deeply alarming. The U.S. is only one of 3 countries in the world where the rate of maternal deaths is rising. Moreover, there is a large disparity in maternal deaths. As you have heard, a recent CDC report found that Black women are 3 to 4 times, and Native American Alaska Native women are 2.5 times more likely to die from pregnancy-related causes as white women. And Black and Hispanic women are disproportionately affected by severe maternal morbidity, defined as life-threatening complications during or after childbirth. And most alarmingly, 60% of pregnancy-related deaths are preventable. This is simply unacceptable when we know these inequities and disparities are avoidable. Inequities and disparities do not have to exist, and we must collectively increase our efforts to close the gap. What is causing these deaths, and why is the rate so much higher, particularly for Black and Native American women? Among the factors that play a role are as follows. Millions of women still lack insurance or have inadequate coverage prior to, during, and after pregnancy. There's increased closures of maternity units both in rural and urban communities, and thereby reduce access to quality maternal care. There's a lack of appropriately trained interprofessional teams in best practices, and that also impacts quality of care. There are structural determinants of health, which include public policies, laws, and racism, and those impact the social determinants of health, which include education, employment, housing, and transportation. Discrimination, racism, implicit biases exacerbate stress, which negatively affects the body and can result in hypertension, heart disease, and gestational diabetes during pregnancy. The evidence tells us that clinician and institutional biases can lead to missed warning signs, can and do lead, I must say, to missed warning signs and delayed diagnoses. Women of color are not being heard. So how do we move forward? Regarding specific solutions, the AMA believes that ongoing surveillance and activities to promote appropriate screening, referral, and treatment are needed. I want to thank the House Energy and Commerce Committee for advancing H.R. 1318. We continue to support the expansion of state maternal mortality review committees and appreciate continued funding to support prevention efforts. We also support the Mamas Act to improve data collection, spread that information from that data on effective interventions, and expand access to health care and social services for postpartum women, and to ensure optimal health for women at risk for medical or mental health conditions leading to maternal death. Additional insurance coverage is required, and the AMA believes that Medicaid coverage should be extended to cover women 1 year postpartum. And finally, let me highlight what the AMA is doing in this space internally in our own house. The medical community absolutely has a role to play here. The AMA recently hired Dr. Aletha Maybank as the AMA's first Chief Health Equity Officer, and she is initiating our new and explicit path to advance health equity through the AMA Center for Health Equity. And although our Center for Health Equity is just getting up and running, there is great potential to partner with Congress to expand implicit bias trainings and other structural competency trainings in medical schools, residencies, and throughout the physician's career. So it will take all of us working in partnership, and the AMA is committed to doing so, to build and continue on a path forward to more holistically and effectively improve maternal health and advance health equity. Thank you.
Thank you, Dr. Harris. We now will call on Dr. Elizabeth Howell, the director of the Blavatnik Family Women's Health Research Institute at Mount Sinai. You have 5 minutes for your testimony. Welcome and thank you.
Chairwoman Eshoo, Ranking Member Burgess, Representative Ingle of New York, and members of the Subcommittee on Health, thank you for inviting me to testify. My name is Elizabeth Howell, and I'm an obstetrician gynecologist and a researcher. I serve as a professor in the departments of Population Health Science and Policy and Obstetrics, Gynecology, and Reproductive Science. I also direct the Blavatnik Family Women's Health Research Institute at the Icahn School of Medicine at Mount Sinai. So we are here today because the United States is in a maternal health care crisis. You have heard that every year in our country, around 700 women die from pregnancy-related causes. Our maternal mortality rate is higher than all other high-income countries, and our numbers, as you've heard, are far worse for women of color. While leading causes of maternal death include heart conditions, high blood pressure, infections, blood clots, rates of maternal death from overdose and suicide are rapidly climbing, and opiate-related deaths have doubled over the last decade. But a maternal death is just the tip of the iceberg. For every death, over 100 women experience a life-threatening complication related to pregnancy and childbirth. Severe maternal morbidity impacts over 50,000 women every year in our nation. Every hour, 6 new moms will have a tragic event like a stroke, a blood clot, or kidney failure. As you heard, the good news is that over half of these tragic events, actually 60%, are preventable if we improve the quality of care women receive before, during, and after pregnancy. Quality of care includes women, no matter who they are and where they live, having access to doctors and nurses who are well-trained, prepared, and equipped with the right tools. It also means having systems in place that make it easy for women to receive evidence-based care. That means hospitals equipped with adequate resources, policies and practices, staffing, and more. If we raised quality of care for pregnant women, we could lower the rates of these tragic events. And quality of care differs for women of color. You've heard that Black women are 3 to 4 times and American Indian women are 3 times more likely to experience a pregnancy-related death than are white women. And in New York City, Black women are 8 to 12 times more likely to experience a maternal death than are white women. Although many want to think that income differences drive these disparities, it goes beyond class. A Black woman with a college education is nearly twice as likely to die as a white woman with less than a high school education, and she's nearly 3 times more likely to experience a severe maternal morbidity. There is a growing recognition that social determinants of health, like racism and segregated housing, contribute to these disparities. And the powerful story you heard from Mrs. Irving about her daughter highlights an additional underlying cause: quality of care, lack of standards in postpartum care. Her daughter was seen multiple times by clinicians after her delivery, but she still died. Reasons for Black-white differences highlight the need to adequately resource programs that enhance quality of care. Research by our team and others has shown that for a variety of reasons, Black women tend to deliver in a specific set of hospitals, and those hospitals have higher rates of severe maternal morbidity for both Black and white moms, regardless of patient risk factors. This is true overall in the United States, where about 3/4 of all Black women deliver in these hospitals, but less than 1/5 of white women do. In New York City, a woman's risk of having a life-threatening complication during her delivery in one hospital can be 6 times higher than in another hospital. Black and Latina mothers are more likely to deliver in hospitals with worse outcomes. In fact, differences in delivery hospital explain nearly 1/2 of the Black-white disparity in severe maternal morbidity in New York City. But it does not have to be this way. We can come up with simple and effective ways to measure and improve quality of care for childbearing women, whether they're Black or white, rich or poor, rural or urban. I am pleased today to provide testimony in strong support of a number of elements discussed in the bills. First, development of maternal health quality measures that are patient-centered and address disparities. Authorization of the Alliance for Innovation on Maternal Health, the AIM program, which is a national partnership that works to reduce maternal mortality and morbidity by implementing standardized care practices across hospitals and health systems. Extension of Medicaid for 12 months postpartum to ensure access to needed care. Development and expansion of state perinatal care quality collaboratives to improve quality of care for moms and infants. Support for health care professional trainings to address implicit bias. I would expand this to include training on patient-centered communication, shared decision-making, and actions to address both implicit and explicit bias. And last, I would echo efforts that are already started, but we need more to build a better infrastructure to support data collection and measurement. I'd like to end my testimony by saying that we have to value pregnant women from every community. We can and must do better. I thank you for this opportunity to provide testimony, and I look forward to your questions.
Thank you, Dr. Howell. Members may notice that I'm allowing witnesses to go past their 5 minutes, but I think every word that they have to be instructive to us is really essential. Dr. David Nelson, it's your turn to testify. You have 5 minutes, and thank you again for being here.
Chairwoman Eshoo, Chairman Pallone, Ranking Member Walden, Ranking Member Burgess, and members of the Energy and Commerce Subcommittee on Health, thank you for inviting me today. I'm an obstetrician and gynecologist with fellowship training in maternal fetal medicine, and I'm the chief of obstetrics at Parkland Hospital in Dallas, Texas. Parkland is one of the largest single public maternity services in the country. Last year, we delivered 12,671 women. This is more deliveries than 10 states in our country. As the medical director of this service, I would like to share my appreciation of this committee for their efforts and celebrate the Preventing Maternal Deaths Act that encourages state programs to establish maternal mortality review committees. However, as you know, our work is not done. A single preventable pregnancy-related death is one too many. Mr. Johnson's testimony last year to this committee and Shalon's mother's testimony today emphasized this issue. So what are the next meaningful steps? To answer this question, I offer 2 themes. 1, access to prenatal care, and 2, use of relevant quality data. The significance of access to care depends on how the issue of maternal mortality is framed. The findings of the Texas Maternal Mortality Review Committee from last year were that the majority of pregnancy-related deaths could be prevented. Similar to other reports, there was a significant racial disparity. Women of color were significantly more likely to die when compared to non-Hispanic white women, and the majority of these deaths under review were Medicaid funded at delivery. So how can we address pregnancy-related deaths that are potentially preventable among women of color in receiving Medicaid funding? I offer our experiences from Parkland Hospital as one strategy. Parkland is unique. It represents a public hospital serving almost exclusively medically indigent women. Of the more than 12,000 women delivered last year, 90% were Medicaid funded. At Parkland, there has been a concerted effort to improve access to prenatal care, and today, there are 10 clinics located throughout Dallas County. These clinics are in the neighborhoods where our patients live and are often co-located with pediatric services to enhance patient use. Of the more than 12,000 women delivered in 2018, 97% accessed prenatal care. These clinics also serve as the medical home for our patients, with important follow-up for services like blood pressure surveillance and depression screening after delivery. The system has administrative and medical oversight that is seamless. The same protocols are used by nurse practitioners at all 10 sites, and this guarantees consistent care that is standardized for referrals of high-risk women to a centrally located clinic. Not all complications, though, can be identified before delivery. At the hospital, a multidisciplinary team of nurses and providers work together according to standardized protocols. Individualized care is stratified based upon medical acuity and risk for complications. For example, we have standardized management strategies for response to obstetric emergencies like hypertension and hemorrhage. This emphasizes a culture of safety with continuous quality improvement. Recently, we have implemented an urgent request to the bedside function with our nursing partners to electronically track and monitor a timeliness to a patient's bedside for immediate care. These efforts dovetail Parkland's participation in the newly formed regionalization program known as Maternal Levels of Care, as well as the Alliance for Innovation on Maternal Health. These initiatives share similar principles with the California Maternal Quality Care Collaborative. Putting this together, access to prenatal care is considered one component of a comprehensive public health care system. It's community-based and extends to the inpatient care setting for a standardized approach. An example of how access to prenatal care translates to improved outcomes: the maternal mortality rate during pregnancy and at delivery for the 3% of women that did not access prenatal care is more than 25-fold higher than those that have prenatal care access at our hospital. Moving to the second theme, how do we measure quality? An obvious method is to track rates of maternal mortality. This, unfortunately, is easier said than done, and our hope is the recent passing of the 2018 legislation is a key step forward in this effort. Another method of assessing quality is measuring rates of severe maternal morbidity, or SMM rates. These are unexpected outcomes that result in significant consequences to a woman's health, like hysterectomy or transfusion. These rates are almost universally derived from hospital billing codes, simply because no other data sources are available. We must consider the potential unintended consequences of tracking such metrics, especially transfusion, because this can become a perverse surrogate of quality. If a provider hesitates, or worse, withholds a transfusion of blood, then a patient may have a risk of mortality. It's critical we use relevant data to guide our policies. Thank you again for this opportunity to share our experiences from Parkland and our efforts to establish access to care. Also, thank you for your understanding of the importance of the relevant quality data. Ultimately, these efforts can lead to safer deliveries of mothers and their infants for the future generations of our country. Thank you.
Thank you, Doctor. Ms. Usha Ranji, you are now recognized for your 5 minutes of testimony. You can proceed, and thank you.
Good morning, Chairwoman Eshu, Ranking Member Burgess, and members of the committee. I am Usha Ranji, Associate Director of Women's Health Policy at the Kaiser Family Foundation, a nonprofit, nonpartisan organization that provides health policy analysis. Thank you for inviting me to testify about the role of Medicaid coverage for pregnant and postpartum women. I will highlight 3 main areas: research on the importance of health coverage for babies and mothers, the role of state policy decisions on access to care during and after pregnancy, and some of the current efforts to close gaps in postpartum coverage. Medicaid is the primary source of health coverage for low-income women and a major financier of maternity care. In the mid-1980s, in response to rising rates of infant mortality, Congress and states saw an opportunity to use Medicaid to improve birth outcomes by expanding the program to more low-income pregnant women and children. Today, the program finances more than 4 in 10 births nationally and more than half in many states. Research shows that women with Medicaid coverage consistently fare better than uninsured women on several measures of access, including greater use of timely prenatal care. More recent research suggests that Medicaid expansion is associated with the narrowing in racial and ethnic disparities in infant outcomes. Our work at KFF finds that low-income women with Medicaid use care at rates that are comparable to their privately insured counterparts. And there is broad agreement that access to care before and after a pregnancy is essential for prevention, early detection, and treatment of some of the conditions that raise a woman's risk for pregnancy complications. Medicaid plays a critical role in promoting access to that care. Maternity care is one of the benefits that all states must cover under Medicaid. Eligibility for Medicaid is based on decisions that states make within federal guidelines. Federal law requires that all states cover pregnant women with incomes up to 138% of the federal poverty level, which is just under $30,000 a year for a family of 3. But most states cover pregnant women with higher incomes, recognizing the importance of coverage during the perinatal period. Yet, after a woman gives birth, there is no requirement to continue Medicaid coverage beyond 60 days postpartum. Historically, many women would become uninsured in the months following pregnancy as a result. But policymakers have opportunities to improve coverage for postpartum women and their families. States across the country have made different decisions about whether to expand Medicaid under the ACA. In the 14 states that have not changed their Medicaid program eligibility levels, postpartum women cannot stay on the program unless they requalify as parents. However, in these states, eligibility for parents is much stricter than for pregnant women. For example, in some states, a new mother would loses Medicaid coverage 2 months after giving birth if she and her partner have income above $4,000 a year. Federal subsidies are available to help some lower-income mothers
Can you say that one more time?
Sure. When we look at the eligibility criteria for parents, it is much lower than it is for pregnancy under Medicaid, and it's state-determined. And in all states, it's actually lower for pregnancy, and in some states, it is as low as $4,000 a year for a family of 3. Federal subsidies are available to help some lower-income mothers purchase private marketplace insurance, but when a mother's income falls between her state's Medicaid level for parents and the poverty line, she does not qualify for either Medicaid or private insurance subsidies. Today, a handful of states are exploring options to improve Medicaid coverage for women after pregnancy. All states can set and raise the income eligibility levels for parents, and that is without adopting the Medicaid expansion. Earlier this year, Illinois approved extension of postpartum coverage under Medicaid to 1 year. Policymakers in Missouri and California have also proposed extending coverage for mothers in need of substance use treatment and mental health care, respectively. So these are a few examples of efforts to enhance care and coverage for low-income moms. Madam Chair, members of the committee, the research is clear. Having health coverage before, during, and after pregnancy promotes access to care, and lack of coverage is associated with poorer health outcomes. Furthermore, our understanding of the health needs of women shows that the postpartum period has evolved beyond one visit. Yet in more than a dozen states, Medicaid coverage ends 2 months after childbirth, even though for a mom, her need for care does not end then. And in short, there is strong empirical evidence to support what families across the country already know and experience on a daily basis, that a mother's ability to care for her own health and well-being is integral to her ability to do the same for her children. Thank you.
Thank you, Ms. Ranji. Those are some startling numbers that sounds like you have a child and then the system becomes punitive. The witnesses have now concluded their opening statements. We're going to move to member questions. Members each have 5 minutes to ask questions of our witnesses, and I'll start by recognizing myself for 5 minutes. There are many layers to this, but I want to go back to where we began with Ms. Irving and many of the things that she said in her testimony to us. She said that we need to hold healthcare professionals accountable for improving the quality of care and ensuring equity. Her daughter has had, I think, more education as one person than most members sitting on this dais. So she was not low income, she was not uneducated, and it seems to me that that a racial bias is alive and well in this area of giving birth and what happens postpartum. Let me ask Dr. Harris, What is the AMA doing about this? I mean, it seems to me that you can track the hospitals where women of color frequent those hospitals than others. I mean, I think the statistics are really very clear. This is not a foggy picture. We heard Dr. Nelson talk about their very purposeful training. So what is the AMA doing before you came to the witness table? Have you targeted the hospitals? Is it red light and siren to do something that addresses this? Maybe you can just briefly explain to us what the AMA is doing. And if you're not, what you plan to do, to be fair.
Thank you, Chairwoman. From the AMA's standpoint, we would see our audience as impacting the physician community. Certainly, I heard from Dr. Howell, though, that there's value in hospitals developing standards, and it would be the recommendation that those standards include some metrics for evaluation.
That hasn't begun yet in terms of the AMA partnering with hospitals and doctors?
No, we have not worked with hospitals to develop any specific metrics, but we are starting internally. As I mentioned earlier, we have just hired Dr. Aletha Maybank, and she's our first Chief Health Equity Officer. And that is building on the work that we already have been working on from our Commission to End Disparities.
Obviously, the causes of pregnancy-related deaths differ. The doctors on the panel, what I want you to instruct us about, because we know heart disease and stroke cause most of the deaths overall, obstetric emergencies, severe bleeding, amniotic fluid embolism cause the most deaths at delivery, but severe bleeding, high blood pressure, and infection are the leading causes in the week after delivery, and weakened heart muscle is the leading cause in deaths 1 week to 1 year postpartum. This is in our memorandum to from the committee staff. How best do you recommend to us to pursue each one of these categories? And for the life of me, I don't understand why the doctors that are trained in this, I mean, this is a specialty, as our ranking member is, that these deaths are a result of these areas, and as you said, Dr. Howell, they're preventable. Where have we gone wrong? Have they forgotten what they learned? Is their training not up to snuff? Can you be instructive to us on that? Dr. Howell?
Sure. So you bring up a really important point, which is what we're pushing for through ACOG and the Alliance for Innovation in Maternal Health. We need standardized care practices based on evidence-based medicine on our labor and delivery floors. And that's not the case now. Well, we do. No, so AIM has started a few years ago, and it's growing in numbers. It now reaches 27 states. And these are partnerships with hospitals and health systems, departments of health, caregivers, to try to work together to improve quality and safety. And we don't just target the most preventable causes like hypertension, blood clots, et cetera. We also target additional things. We've come up with an AIM bundle on how we might address reducing disparities in hospitals and health systems with some key steps that we recommend. We also have, as part of this effort, it's very much a data-driven effort, so we have quality, we have measures and metrics that we're trying to use to utilize and examine how hospitals are doing, which we think is a very important part. So we can't only implement, but we have to evaluate to make sure that what we're doing is the most meaningful way. So that's one big effort that's been going on for about, I believe AIM started in about 2015, and it's very much a partnership.
Well, thank you very much. My time is up, but I also think the American Hospital Association has to lean in on this as well, because the statistics can be traced right back to where women of color, what hospitals they go to, and the number of deaths there. So, or the tremendous complications that follow. But my time is My time is up. So the chair will now recognize the distinguished Dr. Burgess, the ranking member of our subcommittee, for his 5 minutes of questions.
Okay, thank you. Dr. Nelson, you looked like you wanted to say something. Can I give you a moment to respond to previous discussion?
I agree with Dr. Howell that part of the issue is our view. We have not had the full view that we need to see. There's the issues surrounding pregnancy, delivery, and then now subsequently postpartum. One of the issues we need to recognize is the process measures that need to be in place, meaning our response that's consistent to emergencies like hypertension and hemorrhage. Things like a massive transfusion protocol, where we directly get blood to the patient's bedside that needs help. Processes like simulation to train our team members in a safe environment. And then we need performance measures that are meaningful to track data and identify quality and sincere efforts to improve that space. That, I think, is a major step forward for us collectively that we're trying to see.
And since you're talking about it, and once again, I want to thank you. You were very kind to show me around the new unit at Parkland Hospital. They've just moved into new facilities, so it's different from what it was back in the 1970s when I was there. But I was impressed that there are some of the things that I learned in the 1970s that are still appropriate today, but you've also made things different in a number of ways. One of the ways that really impressed me was the availability of I guess an emergency bleeding cart that would be just footsteps away, and you had several of them strategically positioned throughout the labor and delivery unit so that the response time could be significantly reduced. Dr. Howell, in her written testimony, talks about coming into a scene where someone is exsanguinating an hour after delivery. We had a hearing last year, Mr. Johnson, whose wife had a bleeding complication after cesarean section. Can you speak to that and how these the urgency with which the situation is responded to has helped you in managing this crisis?
Yes, sir, and Dr. Howell is absolutely right. Time is of the essence in these emergencies. Our labor and delivery suite is over the size of a football field. There are 44 labor and delivery rooms. And in partnership with the Maternal Levels of Care program for Texas and in alignment with the AIM program, we have 4 hemorrhage carts on our unit. These are carts that contain specific resources, specific instrumentation and needs that a nursing team or physician team might need to immediately respond to a hemorrhage event. We debrief after every time we utilize a massive transfusion protocol, meaning every time we activate a massive resource allocation to a patient, we debrief with the team to understand if there's opportunities to learn from the nurses or physicians. We use multidisciplinary simulation, where we train in an environment with nursing, nurse midwives, anesthesiologists, and team members. We formalized a checklist that's consistent with the AIM platform. We have the hemorrhage cart that we mentioned. We also perform daily huddles for every scheduled surgery that we perform, and because our service deals with a fair number of women with what's called placenta accreta spectrum disorder or morbidly adherent placentas, we actually have a dedicated team of maternal fetal medicine faculty and pelvic surgeons for those cases.
Yeah, for people who don't know, that can be one of the scariest situations you can encounter. So let me ask you this. One of your predecessors, Dr. Norman Gant, who was the chairman of OB-GYN when I was a resident back in the 70s. I forget what he was haranguing us about one day, but he was famous for doing that. And he was giving us the business about how he was worried that his residents were giving care without caring. And he wanted us to be sure to delve into the interpersonal part of the relationship with the patient and being able to being certain that we listened to the patient and heard the patient. Some of that strikes me as when Mr. Johnson was here last year and gave his testimony about the problems his wife had after a cesarean section, when we read and listen to Ms. Irving talk about her daughter's problems. I mean, there were some significant things that happened, and I don't want to say there were care lapses, but I'm sorry, a diastolic blood pressure of 118 millimeters of mercury, that's not an appointment to clinic tomorrow. I mean, that's something that needs to be acted upon. So are we empowering people to make the decisions that need to be made when they encounter these points? And either Dr. Howell or Dr. Nelson, since you're the clinical specialist?
I absolutely agree accountability is critical, and tracking that accountability is one issue. And the urgent request to bedside function, we actually have in place to track time from the blood pressure to when a response was seen. To add on to the comments from Dr. Howell and some of our other panelists, there is absolutely an issue of racial disparity in our services. At Parkland alone, we have a diversity inclusion officer. We have an instructor-led course once a month on this issue, and every new hire has to go through that because of our environment served. That's a commitment that we have at our organization.
And I would just stress that because of the environment served, you are basically what would be described as an inner-city hospital, and you deal primarily with the indigent population of Dallas, Texas, Dallas County, Texas.
Yes, sir.
Thank you. Thank you for being here today. Thanks all of you for your testimony. It's all been very, very enlightening. I'll yield back.
The gentleman yields back. I now would, let's see, where's, Frank is not here. It's a pleasure to recognize the gentlewoman from California, Ms. Matsui, for her 5 minutes of questioning of the witnesses.
Thank you very much, Chairwoman Eshoo and Ranking Member Burgess, for holding this very important hearing. Like our witnesses here today, I'm deeply concerned about the rates of maternal death and severe maternal morbidity in this country that's supposed to be one of the most developed countries in the world. And a special thank you to Ms. Irving for sharing your family's loss. I'm so sorry. Keeping our mothers and babies safe and healthy is vital. As a co-sponsor of last year's Preventing Maternal Deaths Act, I'm pleased that we're building on this effort to address the outstanding racial and ethnic disparities that exacerbate poor maternal health. Extending Medicaid coverage for maternal health services across the continuum of care is a critical next step, and strengthening the quality measures and training programs will help protect our mothers and babies when care is delivered. I thank the committee for prioritizing a hearing on this issue. Several of you pointed out in your testimony the uncomfortable truth that a significant portion of severe maternal disease and death is preventable. It is clear how critical Medicaid coverage is to ensure access to care and avoid preventable maternal health complications. Dr. Howe, you touched upon how quality of care pertains to both clinician practice and system policies. In your holistic view, what is the link between coverage and quality of care?
So coverage is essential, and I think we heard from Ms. Ranji about how important coverage is, preconception, antenatal, during delivery, and postpartum, and the growing awareness that, a third of these deaths are happening in the postpartum way out period.
Right.
We're talking about cardiomyopathies, we're talking about suicides, we're talking about women dying from things that we could do something about, but we have not been giving adequate access to care. So it's instrumental, and it's a key link.
Okay. In Sacramento, we have been looking at, through a Black Child Legacy campaign since 2015, on this whole area of maternal death, prenatal, postpartum activity, and we've come across quite a lot of activities that have really increased our chances here in Sacramento County, and we're really pleased to see that most of the country is sort of looking at how we're doing it too. In Sacramento, we also have cultural brokers at one of our FQHCs, the Well Space Health, that help to engage and support pregnant women by integrating medical care, parental education, and community resources for housing and transportation into a prenatal program for families. It has to be all-inclusive, as you know. This comprehensive model has led to rates of premature and low birth rate that are significantly below the national average. Dr. Harris, it sounds like the AMA is doing some interesting work around social determinants. Can you elaborate on how you envision health plans integrating social and environmental data to better address a mother's unique needs, and how will this lead to healthier babies?
Absolutely, and thank you. And the structural and social determinants of health are critical as we understand how to address this issue and actually other healthcare crises. We have to look at transportation. Is there access to get to prenatal visits? We have to look at other social supports to make sure that our pregnant moms get to their prenatal visits. For moms who are pregnant and diagnosed with depression, we have to make sure that they have access to psychiatric care and care for therapy. And so addressing housing and education and employment are all critical as we address actually this issue, but really all health issues.
Sure. Both you and Ms. Ranji made it clear that mental health care throughout the pregnancy is paramount to improving the health of mothers and their babies. Would you both expand on the trends of maternal mortality with regards to mental health? What is a link between depression and pregnancy and maternal outcomes? You want to take this one, Ms. Ranji?
Thank you. I'll let Dr. Harris and my colleagues comment on the clinical
Sure.
aspect, but I will say, what we've heard from all of the other witnesses is that maternal mental health is a very serious issue. It is a contributor to the maternal mortality and morbidity rates that we've been seeing. And that is, what we know is that is an issue that does not resolve in perhaps 2 months' time, that
Right.
is an ongoing chronic condition that could require various levels of care depending on a woman's individual situation. And so access to care and services is likely needed for an extended period of time.
Okay, I wanted to follow up. Dr. Nelson, what mental health care services are offered to women through your clinic's healthcare home model? And why is mental health care both before and after birth so vital?
I appreciate you asking that. Mental health is critically important. In Texas, in our maternal mortality reviews from 2012 to 2015, there were 33 suicides and 85% were postpartum. In 2013, I published a paper screening 17,000 women with postpartum depression. We identified rates consistent with other populations served. Only 22% made it to a psychiatrist that were identified to screen positive. From that, our service identified an opportunity. We now have mental health counselors placed strategically in all 10 clinics, similar to the home you described.
Right.
Recently, we've actually exercised telehealth and telemedicine with virtual visits. Last year, 1,100 phone calls were made by those mental health counselors to the patients at their home and at their work for those that can't access the clinic directly.
Oh, that's wonderful. Thank you very much, and I know I've run out of time. I yield back.
Gentlewoman yields back. Pleasure to recognize the ranking member of the full committee, Mr. Walden, for his 5 minutes of questions.
Thank you, Madam Chairwoman. And again, thanks to all our witnesses for your testimony. Dr. Howell, as I mentioned in my testimony, we have more to do on maternal mortality and morbidity, but we took a good first step, I think, in the last Congress with H.R. 1318, the Preventing Maternal Deaths Act, which, as you know, became law. That bill reauthorized key CDC programs to improve data collection and reporting around maternal mortality. That'll help support state review committees like the one set up in my home state of Oregon to study these issues. Dr. Howell, you're set up in New York, as I understand it, but your organization does national research. How has the work of the state review committees informed Alliance for Innovation on maternal safety, and quality improvement initiatives?
So the maternal mortality reviews around the country are key and essential to the program for AIM because they teach us about each death and where are the preventable moments. What are the things we really need to work on to prevent a death? And then that information is brought to the perinatal collaboratives using some of the tools that AIM has brought together. And that's the way that we can implement. We learn from the deaths, we take data and information, and then we act on it. And I think that's why these partnerships with the CDC, AIM, are so important. But we need all states to have maternal mortality review committees, that we need them all to review their deaths.
Right.
We need them to submit them to the CDC so that they can have a central system for monitoring. And so we still need to continue to improve our data acquisition and management.
But it's fair to say where it does exist, it's working. You're getting what you need, you're seeing the information flow, which allows then a positive response.
So I think it is mixed in the sense that, yes, there are places that it's really working and you're seeing a lot of movement and you see a lot of positive energy around this.
Right.
Sometimes the resources are not fully there yet, and so some places are not able to actually, do as well as others.
Okay, good. Dr. Harris, it's important to look at every factor related to maternal mortality and morbidity, but one piece I'm worried about is the mental health has been discussed here already. And in your testimony, you mentioned that depression in pregnancy is associated with poor maternal outcomes, including maternal death. We've tried to take the lead in this committee on reforming America's mental health laws, but we all know there's more work to be done, especially for mothers with postpartum depression. And I must say, as a footnote, I was deeply disappointed in my own state. The governor and the legislature actually cut mental health support funding in my state, and why I cannot imagine, but in town halls and other meetings I had this August, I learned the legislature just did that, and it's stunning. You say it occurs in nearly 15% of births. That's staggering, especially considering some of the dire outcomes we now know about. Are the state maternal mortality review committees capturing these outcomes, and are there ways that we can do better?
Actually, I'll have to defer to my colleagues who are obstetricians to maybe talk more about whether or not that data is captured. But I will say, if it is not captured, that is certainly an opportunity gap. We have, as you noticed, I think from the last 30 years or so, had a mental health system, no infrastructure, severely underfunded, and we certainly need to catch up if we can overall, but particularly in this issue. You heard Dr. Howell talk about suicide. I think for many years there was a misperception that depression was normal after the birth of the baby, that it was the baby blues. And so it is critical and there are some emotional swings that do occur, but those are not what we are all talking about with the diagnosis of a major depression. And we have to make sure that the major depression is treated if it's identified within the first visit. Depression is a chronic disease, and it will need treatment sometimes for a lifetime.
Right.
But certainly it's not just to take a pill and your depression will be cured. So this is a huge issue, and we certainly have a long way to go funding for mental health overall, and certainly as it regards to postpartum moms. I'll say one more thing, and there's some great research, and don't have time, but I think we provided this to the committee staff from the Center on the Developing Child at Harvard University that talks about the importance, of course, we all know the importance of brain development in the first 2 to 3 years, but moms who are depressed are perhaps not interacting with their children in a way, and it may impact even the architecture of their brain development. And of course, later, there are all sorts of negative impacts from that. So many nuances to the importance of mental health care for pregnant moms.
That's a really important point that could easily be overlooked, is that interrelationship. Yeah, thank you. Thank you all for your testimony, and we will keep you in our hearts. Thank you, Madam Chair.
Gentleman yields back. Thank you. I now have the pleasure of recognizing the gentleman from Massachusetts, Mr. Kennedy, for his 5 minutes of questions.
Thank you, Madam Chair. Thank you for calling this important hearing. Thank you to all of the witnesses for being here, for the work you do every day, and for lifting up the voices that need to be heard. It's easy to study the stats, to hear some of these stories, to learn about the inequities and implicit bias, to look into the eyes of a spouse, a parent, a child, and to talk to a survivor and become, candidly, a bit dejected. To begin to question why we can't, in this nation, protect mothers like the rest of the world can. To ask why nearly 1,000 American women die from pregnancy and childbirth every year. And why do another 65,000 nearly die or bear those scars for a lifetime? The tragic truth is that we already know the answer to these questions. A long and pernicious history of racism calcified in our institutions, including our healthcare sector. Economic inequality that leaves entire communities relying on unfunded, unprepared hospitals already stretched too thin, and a politically motivated decision by many states to reject Medicaid expansion that leaves thousands of women uninsured less than 2 months after giving birth. So to begin with, Ms. Irving, words will never suffice, and there's nothing we can say or do that will make up for the preventable loss of your daughter. But please know that we will carry her story with all of us. In your testimony, you told us about implicit bias training and that it isn't enough, and you are absolutely right. What systemic reforms would you like to see in our healthcare system beyond that mandatory training?
I'd really like to see some type of a program policy, standardized, what would you call them? I guess standardized policies that are tied to either accreditation or funding. That's, I think, the only way you're going to get people to move off the dime. The implicit bias training is great, but you need to have some kind of evaluation on whether or not that is making a difference in the lives of patients, mothers who are coming there. And if it is not, if it is causing harm, then they need to be held responsible, whether it's funding cut, whether it's accreditation that's withheld, or however you want to put it. But there has to be an incentive for folks to do the right thing.
Thank you. Ms. Ranji, when nearly half of American counties do not have a single practicing OBGYN, and there are stark divides across access to care within cities like Washington or Boston, would adding doula services as a covered benefit under Medicaid, as, by the way, a bill introduced by my colleague Ayanna Pressley, the Healthy Mommies Act, would do, would that increase access to care and reduce rates of preventable maternal deaths or complications?
Thank you for the question. Currently, you raised the issue of doula services. Currently, doula services is covered under, as far as I know, 2 states, Oregon as well as Minnesota under Medicaid. It is a benefit that is not available to many women covered by Medicaid across the country. It is an area that has been of interest in many states. New York is also piloting a program, and several other states have considered recently adding doula services. Doula services could be an important source of support for pregnant and postpartum women. Doula services have expanded beyond just labor and delivery. I'm not familiar with the research necessarily tying it to rates of maternal mortality or morbidity or the effect of that, but there is a lot of research, particularly the Listening to Mothers survey, that has looked at women's perceptions and around doula care and have found it very useful. And perhaps some of my clinician colleagues here could speak to working with doulas.
Thank you. And just very briefly here, a question for each witness if I can. Can any of you tell me how many postpartum women die annually from suicides or accidental overdoses?
I can speak to the Texas Maternal Mortality Review, and from 2012 to 2015, overdose was the #1 cause. And from 2012 to 2015 in Texas, there were 33 suicides.
No national figures, though.
I do not have that, no.
Nobody. And to be clear, we do not have any idea how many women die in this country after giving birth from suicides or accidental overdoses because it's never been studied and it's not reported. So we can't address something we don't know to be a crisis if we don't even know how big a crisis that it is, yet I think we can all acknowledge that it certainly is one, and Doctor, given the statistics that you indicate. But we also can't wait for years for these studies to take place before we act, and that's why we need to have perinatal mental health providers in these conversations and why we need to have guaranteed Medicaid coverage for a full year after birth. Grateful to all of you for being here today. Thank you for your attention to a critical health crisis in our country. Grateful. Yield back.
The gentleman yields back, and thank him for his questions. I gave birth to 2 children in 1969 and 1971, which means they're both older than I am now. But when I complained to my doctor postpartum after each birth how depressed I felt, I was told that's just the way it is. So I just placed that on the table for everyone to think about. And now I'd like to recognize the gentleman from Michigan, Mr. Upton, who served as the chairman of our full committee and with special leadership qualities.
Well, thank you, Madam Chair. I know that we all appreciate today's hearing. Want to do what we can, particularly on a bipartisan basis, to resolve this. You know, every one of our districts is different. All of our states are different. My district has a central city of Kalamazoo, 100,000 people, and some rural counties as well. In the past, we've had some counties without a hospital to help, so people literally had to go out of their county that they reside in if they were going to deliver at a hospital, and obviously that happens. Michigan's got a pretty rural area, particularly in the UP, and we had pretty high death rate, maternal in Kalamazoo back in the 90s, and we worked very closely with HHS and got some special money to grant to really target Kalamazoo to see what we could do to alleviate some of those terrible statistics that are there, which go right along with what you've been saying. Women of color, Hispanics, Medicaid births at our hospitals generally are over 50% and have been for some time, whether it be either in a urban setting or maybe a rural hospital as well. And I'm told, Dr. Nelson, I've heard of Parkland Hospital. I don't know how many hospitals are in Dallas. And it seems like you have done a remarkable job at trying to really reach out with the satellites and others. And I guess the question is a little bit of a follow-up to Chairwoman Eshoo, to Dr. Harris. So when you see these statistics that are out of sorts, bad, things that none of us would accept, what collaborative efforts, and I guess, Dr. Howell, I asked you to be part of this since you're with Mount Sinai, so thinking about the hospital situation, what efforts are you taking on yourself to say, what can we work with? How do we work with the AMA and others to try and duplicate a success that we've seen? I would call it a success of what we've seen at Parkland. Maybe if the three of you could chat a little bit about that. I've got one last question for Dr. Ms. Manji at the end as well, but maybe if you could just expand on that a little bit. Because we see these statistics, what are you going to do? What's happening? Where's the leadership to try and get it done?
So in New York, we've had a lot of work around this for the last 4 to 5 years when we recognized that we were doing so poorly as a state and the significant racial and ethnic disparities that existed. So at the state level, we have had a collaborative across all the states trying to implement some of the AIM bundles, 3 of those bundles in hospitals across the state. And in New York City, the Department of Health has had a lot of efforts trying to work on quality improvement, implicit bias training to do so. At my own institution, we've done a lot of similar things that Dr. Nelson has mentioned in terms of trying to standardize care, building a culture of safety and equity. We've had implicit bias trainings and required it of our obstetrician gynecologists. In fact, we've had all sorts of different things. But one other point I would like to just quickly raise is a lot of the research that I've done has been really looking at New York City hospitals. And part of the story here is some hospitals don't have the resources, have the know-how to be able to implement these bundles and do these things. It takes resources. You need protected time because you need a partnership between physicians and nurses, a physician and nurse leader to champion these efforts. And so while it is in part healthcare professionals and the way that they treat patients, another big part of this story is that place matters and where you deliver matters, and the resources, the staffing, some of the basic bread and butter of high-quality, efficient hospitals is just not there. And that's something else we need to be thinking about.
So just to comment, so a little bit later, all of us here support community health centers, all of us, everyone on this committee. It's been a great bipartisan effort for many, many years. And I know I'm meeting, and I've been to all of my community health centers. I'm going to be meeting with some of my folks from Michigan this afternoon. I'm going to follow up with questions based on this hearing. I know that they're very active, and I applaud what they're doing, and we're going to push them hard. And I would just, my remaining time, Dr. Harris, if you can help, particularly in your leadership role now, I think that would be terrific. And my last question, Dr. Menzie, so one of the things that's come up is, some states have that 1115 waiver to extend the time beyond 60 days that a woman might be able to get some care under Medicaid. Some states have it, some states don't. A couple of the bills that we're talking about today, in fact, have that coverage, which I think is good. I think it's very good. What is the impact on the states? Because again, Medicaid is run by the states, so they have to make the application. So what is the reaction of the states going to be if, in fact, we do this thing that I think most of us could support?
Well, federal legislation would allow uniformity for
So
availability.
they wouldn't have to apply for the waiver. They would automatically just, if they want to do it, they do it.
Right,
So
allow availability of coverage across the country.
Yeah, so my time has expired, but let me just say, so how many states do you think right away would do, how many states have it now, and how many states would say, sign us up?
I can't tell you how many states would say
Back of the envelope,
sign
yes.
us up. I should say Illinois earlier this year
Right.
did approve that policy and is in fact seeking a federal waiver to secure federal financing. But again, if it was written into federal legislation, that would be uniform across the country.
Thank you. I know my time has expired. Yield back.
We thank the gentleman, and he yields back. It's now a pleasure to recognize the author of the Mamas Act, Congresswoman Robin Kelly, for her 5 minutes of questioning.
Thank you, Madam Chair, again. Good morning, and thank you all for being here to share your expertise, your insights, your experiences surrounding this critical issue of maternal health. Mrs. Irving, thank you so very much. It can't be easy, but I just want to thank you over and over again. And Dr. Harris, thanks for all of your support. We could not have written the bill without the expertise and support of the AMA, ACOG. We really appreciate everybody. In recent years, as you've heard today, the number of American moms dying from pregnancy and childbirth has climbed drastically, while globally the rate has declined. New American moms are twice as likely to die today than in 1985. And it's very scary to me. My husband and I have 4 children between us, 3 girls. Only one has had a baby yet. And it's interesting or scary to think that it was safer for me to have a baby than my next 2 daughters, who I think are going to give me grandchildren. After almost 35 years, never know, the situation should be getting better, not worse. As with nearly all health disparities, women of color, especially Black and Native American moms, as we've heard, bear the burden of this crisis and continue to die at much higher rates. In some places, that disparity grows even larger, such as my state of Illinois. One of these mothers was Kyra Johnson, the daughter-in-law of TV's Judge Glenda Hatchett. Kyra raced cars, flew planes, spoke 5 languages. She died soon after giving birth to her second son, Langston. While each death is tragic, the reality of the situation foretells more tragedy. According to ACOG's research, more than half of all maternal deaths are preventable. In Illinois, it said 75% of them are. It's clear that we can and must do more to protect mothers' lives. Conditions like hemorrhaging and preeclampsia can and should be prevented. We must understand the need to listen to women and their health concerns. Just last month, I held a field inquiry in Chicago on maternal mortality. Over and over again, I heard the same problem. Women are not being listened to, especially women of color. The hard truth is that no law can legislate away racism. No laws can change the hearts and minds of people who operate on, deliver care to, or just look at people of color from the lens of unconscious bias. But our laws can change how care is delivered within our hospitals by equipping our providers with standardized emergency obstetrical protocols. Our laws can support providers across their training continuum with tools that help them become more reflexive about how their own biases play out in the care they provide to women of color. Our laws can extend care to mothers who are Medicaid beneficiaries throughout the entire postpartum period. Our laws can support full collection of consistent data about who dies on the way to motherhood and why. Knowing this, I introduced the MAMA Act, which builds on recent successes in data standardization and protocol development to prevent deaths. It also establishes a National Maternity Mortality Review Committee, expands Medicaid coverage for new moms to a full year, and seeks to address the racial disparities in maternal mortality. As chairwoman of the Congressional Black Caucus Health Brain Trust and co-chair of the Congressional Caucus on Black Women and Girls, of prime importance to me is equitable healthcare access and delivery and the healthcare system's impact on those who, before the ACA, historically experienced barriers to care, whether due to cost, geographic isolation, insurance coverage, and especially due to forms of exclusion such as race and the residuals of racism. The time has come for action. We've already lost too many mothers to this crisis, and there are too many kids growing up without mothers because of preventable maternal deaths. And I think that's something this committee needs to look at. How long do we postpone? How long do we keep talking about this as mothers continue to die? It's incumbent upon us to honor their lives with action that will prevent another mother from needlessly dying or another family from being torn apart. We see the inequity, we are calling it out, and we are here to eliminate it. I would also like to enter into the record a statement from Stacy Stewart, President and CEO of March of Dimes, and from Advocate Aurora Health. Thank you again, and I yield back.
The gentlewoman yields back. It's a pleasure to recognize the gentleman from Illinois, Mr. Shimkus. I didn't like the news that went out with your name attached to it, but we have, 16 months left to work with you. So take it away. You're recognized for 5 minutes.
Thank you, Madam Chairman. So appreciate that. And I like the news. So my wife likes the news. So I've been on the ballot since 1988 for every 2 years. So it's time to not be on the ballot. So thank you for those kind words, and we'll get the chance to work together more. Ms. Irving, we grieve with your loss. Thank you for being here. I'm encouraged that this committee is continuing its efforts to understand and address underlying causes of our nation's maternal mortality challenges. As we have mentioned a couple times today, the President signed H.R. 1318, which is preventing maternal deaths, by our colleagues Herrera Butler and Diana DeGette from the full committee. This legislation enhanced federal efforts to support state maternal mortality review committees to improve data collection. I'm going to talk about why that's important. And I'm glad my colleague, Congresswoman Kelly's here from Illinois, because these are most recent stats based upon starting to gather more and better information. In fact, in October last year, October 2018, Illinois Department of Public Health released its first maternal morbidity and mortality report, which found that during 2014 and 2016, there were 231 pregnancy-associated deaths, with the pregnancy-associated mortality ratio being highest for women living in rural counties and in the city of Chicago, 60 to 56 respectively. You know, obviously we mourn every death, and one is too high, but that's just the stats that now we can dig into and figure out what's going on. Understanding that this issue affects a broad and diverse population, it's important to make sure any federal legislation considers the unique needs of states and localities as opposed to a one-size-fits-all solution. For example, Illinois has a waiver to cover mothers up to 200% of the federal poverty limit, and the ACA exchange cover begins at 100% of the federal poverty limit. And this is to Ms. Ranji. Are you concerned that additional federal legislation affecting patients at these income levels could complicate state efforts, or worse, end up punishing states for having made such investments by simply bolstering states and dedicating their resources elsewhere?
Thank you. You know, the federal legislation or a federal would, like as I said before, would add a uniformity to the policy and make it.
Yeah,
that's
that's exactly why I'm asking the question, because if the state of Illinois is better than the federal legislation, then you're penalizing Illinois for what it's trying to do internally to address these concerns.
Well, states would still retain the option and the flexibility that they have now.
We have to make sure that that's available in the legislation. I mean, you can't assume that that's going to be the way the legislation comes out. We have to, that's part of the package.
Certainly, that would have to be part of the terms if that was
right, and that's our concern.
And I would just add, you know, that I think what we've talked about today is that coverage is one part of this whole conversation. And that is one area that states have been making efforts, and has been discussed, you know, states as well as providers, and you alluded to, you know, differences in provider availability in different regions. Providers, states all have a role in this.
Yeah, and states follow the money just like anybody else, and so the FMAP does drive decisions by states, and I think we have to understand that and make sure that these kind of contradictory, sometimes competing messages are directed into the way in which we want them to perform. Let me go to Dr. Howe real quick. In your testimony, you mentioned specific elements of legislation to combat maternal mortality. Specifically, those elements pertain to data collection and support for implicit bias training for health professionals. As a member of the Communications and Technology Subcommittee, we discussed the potential benefits of using big data and machine learning, algorithms and such, but also note that the data we often rely upon to inform decisions is inherently biased. You know, it's that old garbage in, garbage out debate that we have all the time. I'm curious if you or others on the panel could expand on or offer examples of effective ways to limit the negative impact this bias has on patient care.
I think you bring up a really good point about data quality, and I want to echo that if you just use vital statistics alone to figure out the maternal deaths, you're going to miss a lot of the mental health and the late deaths because it's not a reliable system. The pregnancy checkbox, which was introduced in 2003, was introduced differently across all the different states. And so again, you're not dealing with apples to apples comparisons. That's why maternal mortality review committees are so essential, because we're really collecting data from multiple sources on each death. So we really understand what is the underlying cause, what were the contributing factors, and then now we have the CDC trying to have the MARIA program, which is surveillance. 33 states are part of it, to actually collect this information from the MMRCs so that there's now a national understanding of what's going on. We need to get that all the way up to 50 states, but that's the way to have better quality data around maternal deaths.
Thank you, Chairman.
Thank the gentleman. Excellent questions and highly instructive answers. I now would like to recognize Dr. Ruiz from California for his 5 minutes of questioning.
Thank you. While it is stating the obvious, I would be remiss not to say that it is abhorrent that the United States of America is one of only 3 countries where maternal mortality is on the rise, along with Afghanistan and Sudan. And it is unacceptable that 60% of pregnancy-related deaths are actually preventable. Even worse is the fact that the CDC found that Black women were 3 to 4 times more likely to die from a pregnancy-related cause than white women. This is one of the reasons that I have been working on legislation to address health disparities and women's health equity. The Women's Health Equity Act will create a centralized, independent interagency council in the executive branch to facilitate coordination between federal agencies on women's health issues. The problem is that you have different agencies working in silos, and they're not communicating, being efficient in what they're doing, and they're not opening up the resources as well as they could be with efficiency between all the different governmental agencies addressing this issue. This will enhance coordination and communications between agencies when addressing women's health issues and health disparities. The Interagency Council would focus on collecting and analyzing programs currently in place and give recommendations on how to better coordinate their efforts. The Council would also be responsible for monitoring, evaluating, and providing recommendations to address women's health equity and health disparities. It would also streamline programs and activities within federal agencies that are working towards the same goals. Dr. Harris, do you agree that the lack of coordination on the federal level is hampering efforts to truly address health disparities?
Well, what I would say is you bring up a great point about the importance of getting out of our silos, and interagency coordinating councils are a proven method to do that in other disease and public health crises. And so I would say that any opportunity where folks get out of their silos and work together and agencies coordinate their efforts better is a step in the right direction. I would say from the AMA standpoint, we would hope that there would be physician input into any of that agency coordination.
Well, just to let you know, AMA has been very active in contributing their input into this legislation. Dr. Howell, what's your thoughts on that?
I agree with what Dr. Harris said, that, you know, us working together, collaborating, and sort of figuring out the next steps, having the voices of many parties, including physicians, in this discussion is really important.
Excellent. So, you know, I grew up in a farm worker community where residents were largely poor, with English as a second language. And as a kid growing up and later as a doctor who practiced medicine there, I saw firsthand how critical cultural competence is to delivering effective, high-quality care. And it's not just understanding terms from different culture. It's a cultural sensitivity where you can understand the practice of truly trying to understand a person's background in order to provide the best therapy and increase compliance and increase success of those recommendations. The Giving Voice to Mothers study released this summer surveyed women in the United States in an effort to learn more about mistreatment during birth, and found that 17.3% of women experienced one or more types of mistreatment, including but not limited to privacy violations, being shouted at or scolded by healthcare providers, or having treatment withheld. Women of color were more likely to report an experience of mistreatment, with 33% of indigenous women, 25% of Hispanic women, 22% of Black women reporting an experience of at least one form of mistreatment. We have heard on our panel today about at least one terrible example of what can happen when a patient doesn't receive the care she is saying that she needs. These experiences further perpetuate mistrust in healthcare systems and influence women's desires to access care. Dr. Harris, in your experience, how can we embed improving the experience of care in efforts to improve the quality of care?
Another important topic, and thanks to the committee members for raising this. There's this whole universe of how we understand and work with others. So you mentioned two terms, cultural competency, cultural sensitivity. I even use the term cultural humility.
Yep.
So we have to appreciate all of these issues in the context. Several of the committee members have mentioned implicit bias, unconscious bias, another part of that universe. What we know is all of us have unconscious and implicit biases.
Well,
how should we, but unfortunately there's no gold standard at this point. And one of the things that AMA wants to do is look at not necessarily developing a gold standard, but what might be the components of a great program to get at all the
I'd love
issues
to
you
work
raised.
with you on that. Just in closing, Chairwoman, we can't look at mortality, maternal mortality disparities if we don't look at the overall health disparities in our system, because a pregnant woman doesn't exist only when she's pregnant, right? So you have to look at her health and her experience with her health, because that's one of the leading factors of health outcome is her health prior to being pregnant. And just recently, for example, as an example of how we have these inherent biases, September 6th, JAMA Open Network published an article that showed that out of over 800,000 women and men under Medicare, they found that Black and Hispanic women were diverted from EMS, from the emergency department designated for them, took a longer trip to send them to the safety net
Thank you,
hospital
Doctor.
elsewhere,
Your time has expired. I
which
hate to
you know
cut
has
off,
dire consequences.
but I am. Thank you. The gentleman yields back. I'd like to recognize Mr. Guthrie of Kentucky for his 5 minutes of questioning.
Thank you, Madam Chair. I appreciate it very much, and thanks, Ms. Irving, for telling your story. We had a hearing on this for some bills that we did pass and signed into law. There was a husband in your seat, and he was talking about his wife, and he made the same arguments that you made. He said his wife, I think he was either a business consultant or private equity. His wife, who I think was a PhD, athlete, UCLA, if I remember, delivered at UCLA Hospital, and then had complications and went back. I don't know if it was how many days it was several days, and she was just dismissed with, you're exaggerating, or so whatever. And so what we're saying here, I mean, I know we're implicit bias, cultural bias, we're using those terms, and they're absolutely accurate. But what we're saying is, because you said it wasn't a lack of education, it wasn't a lack of insurance, it wasn't a lack of access. I think Dr. Howell said that if you control for education insured, African-American women or women of color are treated different than less educated and within coverage for whites. So what we're saying is African-American women or women of color are showing up in front of healthcare professionals, and healthcare professionals are treating them differently. And we need to, if it's a commission, if it's agencies, if it's cross-referencing that we can do in Washington, we need to do that to make sure that this is taken care of. But Dr. Harris, you're the only one here representing a healthcare profession. What's going on? I mean, is the AMA trying to address this internally? I know we're here in Washington trying to address it, but we know there's a problem. We know it's there's bias. And what do you think it is, and what is AMA trying to do to address it?
I think we're trying to find the answers to those questions. And as I mentioned earlier with our new work, and by the way, this is building upon work for many years at the AMA, our Commission to End Health Disparities. Again, I just talked to Dr. Aletha Maybank this morning, and we talked about the possibilities. Now, we are just getting our center up and running, but this is one of the areas where we want to focus on. We want to understand why, and then what are the solutions that physicians can implement. Of course, as you know, I'm a psychiatrist by training, so I'm trained to listen maybe in a different way. But as I said in my testimony, For whatever reason, many of them are racism, discrimination, implicit unconscious biases. Women are not being heard, particularly African-American women are not being heard. So the fact that we're talking about that is the first step, and I know at the AMA that we are going to move forward with that, try to find solutions, and then spread that to the medical community. Of course, our partners at ACOG are here, and we'll work closely with
I want
them.
to correct the record. I think she was a UCLA athlete. She was Cedars-Sinai was the hospital. So I want to make sure I have that corrected. The previous witness, it was her. So Parkland, though, I mean, you have 90% Medicaid, and you have this extensive program. And so I think what Dr. Howell said, in New York City, you have hospitals, and I understand that. It's absolutely a fact. You have hospitals that have better outcomes than hospitals others, and you're saying it's more women of color go to the, they're kind of divided up in where they go to get their service. But what I don't understand in the health, getting back to the healthcare professionals, why aren't they just showing up at, are they showing up at your hospital, Dr. Nelson, saying, what are you doing? How can we replicate it? How can we move forward? I mean, it looks like we're here doing a mandate from Congress, and if Congress needs to mandate it, we need to mandate it. But it seems like within the healthcare professional, they would be flooding to what you're doing, or in New York, some of the hospitals are going to the hospitals having better outcomes. And just, what are you doing different? Because when we did the bill last year, we found that in high-risk pregnancies, some hospitals didn't even have high-risk kits available when they were doing high-risk deliveries, just the basic stuff. And it's hard for us to fix when they're not even doing the basic stuff from Washington. So Dr. Nelson or Dr. Howe, whoever wants to talk about that, it's disturbing that the healthcare profession is not addressing this better than they are.
I think to speak
Now,
first,
I'm not saying you're not.
Well, I think to speak first, you're absolutely correct. And that the first issue that Dr. Harris mentioned is we have to recognize we have a problem. And collectively, we have to agree that we have a problem. And this includes issues within high-resource settings and low-resource settings. And one of the steps forward that I'm proud of is the regionalization of care that we've provided in Texas. And that's not to say we're closing hospitals in rural communities. We support that. It's really to identify women with prenatal care that have a high-risk condition, identify their needs, and get them to a facility that has resources that
Well, I understand what you're doing, but are other hospitals flocking to you from other cities that have this,
Yes.
they're the same diet and trying to understand what you're doing and replicate it?
So that model is one of the opportunities, and it dovetails AIM, and it dovetails the California initiative. These are standardized practices that we can all collectively agree to in the medical community that say.
Because you'd be at
urgent
90%
response.
Medicaid, so you're not at the top of the chain in terms of financing.
But the principles of
But it
care
can be
are the same.
replicated.
The principles of care are the same.
Yes.
And that's emergent response to emergent conditions, and time is key.
Thank you. My time's expired, now yield back.
You thank the gentleman, he yields back. Pleasure to recognize the gentleman from North Carolina, Mr. Butterfield, for his 5 minutes of questioning.
Thank you very much, Madam Chair, and thank you to all of the witnesses for your testimony today. Let me begin with you, Ms. Ranji. Thank you for coming today, and thank you for your words. As you pointed out in your testimony, research shows that health coverage before, during, and after pregnancy is important to support healthy pregnancies and positive outcomes. Medicaid, that favorite word that we all talk about, Medicaid. I wish it was available in every state in the union with respect to its expansion. But Medicaid is a vital program for many families in my district and all of our districts. I'm glad the committee is looking at bills that would extend Medicaid eligibility for pregnant women to 1 year postpartum. A maternal fetal medicine specialist at Duke University in my district shared with my staff recently that extending Medicaid coverage to 1 year postpartum would be life-altering and potentially life-saving for her patients, many of whom have not had regular care until finding out that they were pregnant. Extending Medicaid coverage for new moms is a vital step to ensure these women can continue to be cornerstones of our families. Ms. Ranji, simply put, healthy moms lead to healthy babies. Is that an overstatement? Is that...
There's certainly a lot of research that connects the health of moms with the health of their children, and as well as coverage, that access to coverage for moms also connects to access to coverage for children.
Now, could you describe for me the long-term positive benefits that 1 year postpartum Medicaid coverage would have on moms and their children?
Well, like I said, in several states now, women do lose coverage after 2 months. And so extending to 1 year would provide access, seamless access so that women could continue to see the same providers and follow up on many of the issues, the clinical issues that my colleagues have talked about today, cardiac-related health, maternal, mental health. And again, coverage provides access to a provider and being able to continue and follow up on all of those issues that, again, that we know don't resolve within 2 months usually.
Thank you. Many of the witnesses, Madam Chair, today have commented on the disgraceful and disturbing fact that African American women are 3 to 4 times more likely to die from a pregnancy-related cause than their counterparts. Black women are also more likely to have complicating conditions like uterine fibroids and hypertension, among others, which can cause severe maternal morbidity and have potentially life-threatening and lifelong consequences. There have been countless stories of women dying or becoming ill because their symptoms were ignored or treatments were not offered. What should we do? And let's try you, Dr. Howell, on this if we can. I just looked at your bio. Looks like you're well suited to handle this. What should we do to educate providers about conditions like these that disproportionately impact women of color and how to identify and treat them?
So again, a very important point about risk status for women when they enter our healthcare system, antenatally as well as on labor and delivery. So risk stratification is an important part, and it's something that we use also in our AIM bundles to understand who's most at risk and then make sure that those people are getting what they need and when they need it. So I think in addition to just pure clinical care and thinking about the best way to optimize care for individual patients, we also need to think about some of these other issues around communication strategies, decision-making, shared decision-making, listening to patients to better understand their story, and recognizing and teaching healthcare providers that there is a bias not to listen to women in general, which we've heard in our own focus groups across race and ethnicity, but it's more pronounced for women of color. So I think those are some of the steps that we need to take.
Thank you. Thank you very much. Madam Chair, since Dr. Ruiz went over 1 minute, I'll go under 1 minute, and maybe we can cancel each other out. Thank you. I yield back.
I always knew you were a good man.
Yes.
Always.
He's my friend.
Yeah. Well, you're both my friends.
Yeah.
The gentleman yields back, and now it's a pleasure to recognize the gentleman from Virginia, Mr. Griffiths, for his 5 minutes of questioning.
Thank you very much, Madam Chair. And clearly, somebody said it earlier, we have to identify that we have a problem, and clearly that has been identified. And we heard the testimony last year of Mr. Johnson. We've heard your testimony today, Ms. Irvin, and those losses where the mothers were they just weren't paid attention to. And that clearly is a concern. But I was struck, Dr. Howell, by one paragraph in your testimony. I'm gonna repeat that paragraph because I think it's helpful, and then I'm gonna ask you a question. Quoting your testimony, research by our team and others has shown that for a variety of reasons, Black women tend to deliver in a specific set of hospitals, and those hospitals have worse outcomes for both Black and white moms, regardless of patient risk factors. This is true in the United States overall, where 3/4 of all Black women deliver in a specific set of hospitals, while less than 1/5 of outcomes in those hospitals. While less than 1/5 of white women deliver in those same hospitals. Both Black and white women have worse outcomes in those hospitals. In New York City, a woman's risk of having a life-threatening complication in one hospital can be 6 or 7 times higher than in another hospital. Black and Latina mothers are more likely to deliver in hospitals with worse outcomes. In fact, differences in delivery hospital explain nearly 1/2 of the Black-white disparity and 1/3 of the Latina-white disparity in severe maternal morbidity. So here's my question. They're choosing a specific set of hospitals. How do we fix those hospitals? And should we have some way of getting the information out, if we can't fix those hospitals, that these hospitals are far more dangerous? Doesn't solve all the problems, but your testimony indicates that 1/2 of the disparity is because of specific hospitals. Nothing else that we're doing here at the federal level or the state level, but the specific hospitals they're chosen. How do we fix them?
So I think what's interesting about the work we've done in New York City is that it's not the traditional hospital characteristics. So it's not percent Medicaid. You know, the median percent Medicaid in New York City hospitals is like 80%. So we're talking about a highly, 60% of our deliveries are covered by Medicaid. So it's not volume. It's much more. We don't really understand why there's such variation other than having to go in and talk to hospitals, and that's what our research team is doing. So we're going into hospitals who have low rates and hospitals that have high rates to try to understand what the differences are. And what we're finding is that it is things like staffing. It's things like culture of the culture of the institution and the way that they treat adverse events. It's things like communication and the emphasis. It's quality and safety on labor and deliveries and the use of evidence-based practices, but it's also whether there's any focus on equity and diversity and how they think about it. So more work needs to be done to understand these variations, especially in large urban centers where you have high volume. But that is one key important piece, because in certain hospitals, regardless of what you look like, your risk is higher to have one of these severe complications. And that is an important part of the story we're talking about today.
And so while we look at these bills, and I think this was the same point that Mr. Guthrie was making just a minute or two ago, and he and I hadn't talked about what we were going to discuss, but he started hitting some of that same testimony, is that while we're working on this legislation, that's an area we need to focus on. And right now, while there's some studies in these bills, I don't think the bills are really focused on that area. And maybe we need to give some more money to the NIH to focus in on that so that we can figure out what the problem is. And maybe they need to be doing what Dr. Nelson's doing in Texas, but maybe that doesn't work in New York City, because what works in Texas might not work in New York City. But we still need to figure out if that's half of the problem, then it ought to be addressed in some of our bills as more than just a casual line in a study. Would you not agree, Dr. Howell?
I think that it is one important part of something that needs to be addressed. So yes, I do agree that it's one more element that we need to look at, and a very important one in New York City.
And Dr. Nelson, you'd be more than happy to talk with anybody who wants to figure out what you're doing right. Is that correct?
Yes, sir.
And you'd be willing to work with these hospitals that in the testimony are just listed as, and I'm not asking for names today, a specific set. Dr. Howe, real quick, I just have a few seconds left, but should we identify for the public that those specific set of hospitals where your risk is higher?
So I think that, Dr. Nelson, I think we both agree that measurement is a key. Quality measures that are important and that women can use to help choose hospitals, I think, is an important measure. But we have to be very careful about the development of appropriate risk-adjusted quality measures so we do not penalize the hospitals that take care of the sickest and the hardest cases. And I think that's a really important part of doing really well-done quality measure development in maternal health that focuses on both the patient-centered, thinking about experience, as well as on disparities.
Thank you. I'm out of time. If the chair lady would like to give you time, Dr. Nelson, she can, but I'm out. I have to yield back.
Well, the gentleman yields back, but I think that his question to you is really very, very important. All of the collection of the data is essential so that you have something that's foundational. But we already know where women of color deliver and die. So there has to be, I think there needs to be a red light and siren team that gets into these hospitals. And I also think that we should consider the accreditation of that hospital based on the morbidity rates. So I don't know if that's what where the gentleman was going, but it certainly is my sentiment.
Will Dr. Nelson respond to that?
Certainly.
So one of the comments of sharing, in all seriousness, sharing our experiences and what we do as practices is actually part of the outreach, and one of the things that we actually stress as part of the regionalization of care. We actually have an outreach team going to lower level facilities to talk about emergent response to hypertension and labor management. So that actually is one of the existing programs we currently are using right now.
But I mean, I don't know if El Camino Hospital in Mountain View, California knows what you're doing, and I'm not saying that they have a problem. It's marvelous what you're doing, but this needs to be under a national umbrella, and I don't think anyone is arguing with that. It's a pleasure to recognize the gentlewoman from California, Ms. Barragan, for her 5 minutes of questioning.
Thank you, Madam Chairwoman, and thank you all for being here today, for sharing your stories. The statistics are quite tragic, completely unacceptable in a country like ours. I first learned about the issue of racial health disparities when I was in the White House. I was an intern, and the New England Journal of Medicine came out with a study. It showed that they had sent a African-American woman, a white woman, and a Latina woman to similar doctors, same doctors, complaining of the same symptoms, and they were all treated differently. And that's when I first learned of it, and I think one of the points made by my colleague, Dr. Ruiz, is critically important. It's certainly overall health and making sure that we're all getting access to equal care, but that we're being listened to. And Ms. Irving, I want to thank you for coming and sharing your story of your daughter and the testament that you provided, something that we all needed to hear. And that's why I'm glad we're having this hearing today to kind of look at these bills and see what can be done. It sounds to me there's not one fix. It sounds like there's going to be a series of things that need to be done to fix this issue and to make this wrong right. And so I thank you all for coming. Dr. Howell, two of the bills that we are being presented with and are looking at are H.R. 1898, the Mama's bill that my colleague, Ms. Kelly has, and H.R. 2902, which is a bill that my colleague, Alma Adams, has. Have you had a chance to look at those bills? I'd like to know if you believe those bills might help eliminate some of the implicit bias among the medical professionals.
I did get a chance to look at those bills. I don't have my notes. Could you just repeat the names of the two that you wanted me to talk about real quickly?
Sure. The Mama's Act.
Yep.
And the other one is the Maternal Care Access and Reducing Emergencies Act.
Got it. Yes. So I did have a chance to look at all of the bills, which I, again, think there are elements that are key for this issue. The Mama's Act, authorizing the AIM program, which I told you is the key to having standardized care practices implemented in hospitals and health systems across the United States, currently reaching 27 states. So potential to reach more than 50% of all U.S. births. Very important. We need to authorize that. Second, perinatal quality collaboratives, maternal and infant health quality collaboratives are so important as a tool to improve quality of care and these are partnerships with hospitals and health systems and Department of Health. As you've heard from my colleague, very important to extend Medicaid for 12 months postpartum. You know, there's so many cases of women who have gestational diabetes. They go on to have a risk. They're 7 times more likely to have type 2 diabetes. But if we don't capture them in that postpartum period, they may go on and be much sicker the next time they get pregnant, as well as cardiovascular complications that are so important. And then finally, the regional centers of excellence to address implicit bias and culturally competent care, which we've had a discussion about, which I think is a really important piece. Again, I would expand it to think about patient-centered communication, shared decision-making, because it's not just bias. That's a problem. But we're not doing a good enough job listening to our patients, communicating with our patients, and understanding their perspectives. And so having centers of excellence that really focus more broadly with a focus on explicit and implicit bias, I think, are important. And I think that the Maternal Care Act has very similar themes to it. The Maternal Care Act, though, does talk a fair amount about care coordination and its importance to target social determinants of health, which I think is an important piece. And it calls for a medical home demonstration project, which I think is of interest. My one thought I would just share is that CMMI Innovation Project looked at group prenatal care versus birth centers, which is predominantly midwifery care, versus maternity home care for prenatal services to see if we could lower adverse birth outcomes, lower costs, and improve satisfaction. And the other two models performed better than the maternity home model. So that is evidence that I think we have to include in these discussions. There's no question that care coordination in general seems to really do a good job targeting disparities, and it may need to be a piece, but we need more evidence to make sure, because this early evidence is not telling us it may be the best step forward.
Thank you, Dr. Howell. I also want to mention, I think another component is making sure that we get more people of color into the medical profession that are there to listen, that are there to understand. I'm proud to have Charles Drew University Medical School in my district, which is a historically black graduate institute, that is a district that's 88% Latino African American, that is bringing more and more people into the fold, into these professions. And certainly, if I had more time, would ask about your opinion, but I wanted to certainly say that I think this is another angle we can certainly improve in as well. Thank you very much, and I yield back.
The gentlewoman yields back. It's a pleasure to recognize the gentleman from Florida, Mr. Bilirakis, for his 5 minutes of questioning.
Thank you, Madam Chair. Appreciate it so much. And thank you to the witnesses here who are testifying. Very informative. Dr. Howe, we can't solve what we don't understand. That's why last Congress, this committee passed critical bipartisan legislation, the Preventing Maternal Deaths Act, which provides funding through the CDC for states and other entities to develop maternal mortality review committees so we can start collectively understanding and reducing our rate of maternal mortality. CDC recently announced it's funding the first round. It is funding the first round of grants to support 25 states, their efforts to combat maternal mortality through the creation of maternal mortality review committees. As states prepare their implementation efforts, what should this committee be paying the most attention to?
Well, I think it's wonderful that the CDC is now sponsoring 25 perinatal quality collaboratives. I think the data is a key point. I also want to say one thing, though. You're absolutely right. What we don't understand, we can't really address. But there are models of success. We've heard a lot about Parkland today. If we look at California Collaborative and what they've done by using maternal mortality review committees, gathering the information around deaths, then using that information to drive quality improvement, and they've done a number of the bundles, the same bundles we're talking about for AIM. They started hemorrhage, hypertension, venous thromboembolic disease, and they've actually lowered deaths in hospitals that adopted these bundles by like 21% for the hemorrhage-related deaths. And their maternal mortality rate, while the rest of the United States has been going up, theirs has been going down. So we have evidence that when we tie data to quality improvement, we can really make a difference. The important lesson about California, though, is an additionally important lesson is that their disparities, however, did not decrease. So they lowered maternal mortality for white women, they lowered it for black women, but that gap is still there. And now they're trying to target a lot of the things that the rest of us are trying to target around health equity, combining quality improvement, what the data tells us, with cultural humility, and sort of trying to understand communities, getting them involved to help tackle this problem, which is something that the AIM bundle also tries to do, that ACOG partners with community organizations to get their input about how best we implement these bundles in not only hospitals and health systems, but we get communities on board as well.
Thank you. Are there concerns within the research community regarding the integrity of the data being collected in states? And if so, what are those concerns and how might they be addressed? Are there any concerns with regard to the integrity of the data?
Well, there's certainly concerns with the use of what I had mentioned about if you only base maternal mortality rates on vital statistics data only, that you're only getting a slice of the picture, and it's not a great way of monitoring our trends across the nation. And the CDC now uses vital stats, it combines it with state discharge abstract data, which gives a better estimate. But still, the best estimates are the data from the maternal mortality review committees that actually get multiple sources of data to figure out how this death occurred, what were the contributing causes, and then feeding that back up to the CDC through their Maria program is probably the best way for us to get data on this that we can use for improvement.
Very good, thank you. Last week, the CDC released a report titled Racial Ethnic Disparity in Pregnancy-Related Deaths. In the report, CDC suggested that steps still need to be taken in order to better integrate care delivery between hospital and pre- and post-care services for mothers and their newborns, as well as better management of high-risk patients. How might this committee consider addressing these specific challenges highlighted by the report? And can you highlight any states or entities that can be looked at as models again, best practices in these areas?
So I think that I would echo much of what Dr. Howell just mentioned, I think is reflective in that effort. California has been a model for a lot of the programs, but the same principles are true within the AIM domain. Parkland Hospital publishes Williams Obstetrics as a textbook. It's the most popular textbook worldwide. We have 17 authors on our faculty, including myself. And these principles are the same. The important part of this is disseminating that level of scholarship and information to the community centers, to the communities at large, and the providers in those communities.
Well, thank you very much, and I'll yield back, Madam Chair. Thank you.
The gentleman yields back. Pleasure to recognize the gentlewoman from Florida, Congresswoman Castor, for her 5 minutes of questioning.
Well, thank you. And Chairwoman Eshoo, I want to thank you very much for organizing this hearing here today on the maternal health crisis in America. It's good to see so much engagement by the committee this morning on our first committee meeting back after the district work period. First off, I want to say I'm really proud to be a co-sponsor of Representative Kelly's Mama's Act, and I'm so glad that she joined the committee this year. She is a champion on this issue, and her voice is vital to this discussion, and it is needed. It is just horrendous what is happening with disparities when it comes to maternal health in the United States of America. And I want to thank the witnesses for being here and for providing your expertise. Already I've seen members making long lists of how we can improve the bills that are before us today. Ms. Irving, thank you very much for sharing the story of your daughter. You're very brave to do so, and I know she would be very proud to know that you are carrying on her work. I'm also grateful to the advocates across America who engage every single day, whether it's the March of Dimes, or it's the American College of Obstetricians and Gynecologists, or Every Mother Counts, the folks in the trenches, making sure that whether they might be Healthy Start, making sure that women and families have every opportunity to have healthy children. In the Tampa Bay area, I am very fortunate. We have a terrific Healthy Start Reach Up initiative led by Lo Berry. They're one of the national leaders. But what they tell me is while they have years of experience and they're making progress, they're not able to reach everyone. That we're still not able, after so many years, to ensure that women of childbearing age get the services, get the support that they need. I mean, in America, it's so disjointed. Medicaid and maybe private health insurance, and maybe you're uninsured and you're trying to find a community health center, but that community health center doesn't provide care. It's still not enough. And I was really taken by the comments of Dr. Ruiz and Representative Butterfield, who highlighted this really is a continuum of care that is in crisis. And add on top of it the disparities, the racism that continues, the social stigma probably in many different groups. We've got to do so much more. So I'll look forward to, as we get into the markups on these bills, how we can really tackle this continuum of care. I'm also fortunate back in Tampa, we're home to the University of South Florida. Dr. Judette Lewis is the chair of the College of Medicine's Obstetrics and Gynecology Department. She shared, again, the sobering statistics. In Florida, Black women are nearly 3 times more likely to die from pregnancy-related causes than white women. She said that, yes, the maternal mortality review committees and the perinatal quality collaboratives are helping, but so much more needs to be done. I want to start my questions with Ms. Irving. You've listened. These folks are very smart. Members of Congress has some insightful questions. What would your daughter want to highlight after listening to everyone here today? What would your daughter say? Boy, that's absolutely right. What would she have wanted to highlight to this committee?
I wish I knew. My daughter was a brilliant person. I think what she might say or start off saying is, this is not a new phenomenon. This has been going on for decades. Why can't we get it right? There are things that can be done, but are not being done. I think she would probably say that behind every one of these statistics, there's a woman who's loved, who's missed, and look at the domino effect. Look at the families, look at the children that are suffering because we can't get it right. She would want us to look at making sure that there are the standard care policies and procedures in place, and there is some accountability behind it so that we can make sure that folks are being listened to. I listened to all of your talk and things about people come in and it's the hospitals, and there's certain hospitals where you can't go or where you won't get the same amount of care. That wasn't the case for Shalon. The case was that she wasn't heard. She came in, she presented with the symptoms. It wasn't that she was making it up. She came in with swollen legs. She wasn't voiding. She was gaining weight. She gained 7 pounds in 1 week. And she was there 3 times that week. Her blood pressure was off the chart. She was not only not listened to, she wasn't, her symptoms were not addressed. She was there. She was in a very, very good hospital. She had great doctors in that hospital. She had gold-plated insurance. She was not an ignorant woman. She knew what was wrong, and she kept saying it. I don't feel well. This is not me. There's something going on here. But she was dismissed with the, oh, it's fine. You just had a baby. Give it time. Don't worry about it. I think my daughter was just so tired at that point. She didn't stand up and say, look, I am going to the emergency room, or I'm going to call another doctor, or I'm going to another hospital, or whatever, until somebody listens to me. With a newborn baby, with colic, with respiratory distress, she just was tired. And she needed someone to advocate for her. She needed someone to realize that they had to take care of her at that time. And so I think she would just be off the chart right now, because that's not happening.
Well, let that be a lesson for all of us as we move these bills. Thank you.
Gentlewoman yields back. I now would like to recognize the gentleman from Missouri, Mr. Long, for his 5 minutes of questioning.
Thank you, Madam Chairwoman. In this final round of Jeopardy today, we only have one category left, and that is Who Said It? So in the category Who Said It, for $1,000, after delivering another perfect baby, I was sitting next to Kara by her bedside in the recovery room. That is when I first noticed blood in her catheter. I notified staff immediately. A series of tests were ordered, along with a CT scan to be performed stat. I understood stat to mean the CT scan would be performed immediately. Hours passed, and Kira's symptoms escalated throughout the rest of the afternoon into the evening. We were told by the medical staff at Cedars-Sinai Kira was not a priority. And we waited for the CT scan to be done. We waited for the hospital to act so she could have her recovery. Kira kept telling me, Charles, I'm so cold. Charles, I don't feel right. She repeated these same words to me for several hours. After more than 10 hours of waiting and watching my wife's condition deteriorate, after 10 hours of watching Kira suffer in excruciating pain needlessly and begging and pleading them to help her, the medical staff at Cedars-Sinai finally took action. As they prepared Kira for surgery, I was holding her hand as we walked down the hall to the operating room. Kira looked at me and said, "Baby, I'm scared." I told her without doubt everything would be fine. The doctor told me I would see her in 15 minutes. Kira was wheeled into surgery, and it was discovered that she had massive internal bleeding caused by horrible medical negligence that occurred during her routine C-section. She had approximately 3 liters of blood in her abdomen. Kira died at 12:22 a.m., April 17th, 2016. Langston was 11 years old. As someone who experienced firsthand what it is like to have your spouse die in front of you, I do not have the words to describe the loss my family has suffered. My boys no longer have their mother. Kira was the most amazing role model and mother any boy could ever wish to have. I no longer have the love of my life, my best friend. Of course, those were the words of Charles Johnson IV, who I believe was of means. Kira was of means. It wasn't someone that didn't have good prenatal care. It wasn't someone that didn't have it was a pre-planned C-section. But we're talking here today, and I hear a lot of people talking about access to prenatal care, which of course is vitally important. But cases like this, cases like Miss Irvin's, all I want to do is come down there and hug your neck. I can tell you that. I'm the only Missouri member that's on Energy and Commerce, so consequently I'm the only Missouri member that is on the Healthcare Subcommittee. So I feel an obligation to travel the state for healthcare issues. I visited just during this break a week ago, may have been a week ago today, I'm not sure of the timing, but Kansas City Children's Mercy Hospital. Went through the neonatal, and I do that quite often. I go to St. Louis Children's up there. Our oldest daughter is a pediatrician. And I know when she does her rounds at the hospital that, all that she wants to do, and you'd think all any doctor would do is love these babies and make sure that they get a good start and love the mothers. And so whatever we can do on this committee, I mentioned earlier in my little outburst when we had the outburst in the hall, which I apologize to you all that went on for any length of time during your testimony. I am a member of the Black Maternal Health Caucus, and I deeply care about this issue. The timing didn't work out to bring up H.R. 4215 today, the Excellence in Maternal Health Act. Nobody's fault, just the timing didn't work out, but I'm an original co-sponsor of that. And I just want to thank you all for being here today and your heartfelt testimony. And I've said a lot of words here today, but there's no words to say to express what unbelievable issue this is and the things that happened. But if your testimony here today, Charles's testimony back in September of 18, I believe it was, we've had a lot of big hearings, a lot of memorable hearings in Energy and Commerce. Mark Zuckerberg from Facebook is an example. Jack Dorsey of Twitter, the room were packed, a lot of, but no hearing ever moved me like Charles Johnson's testimony that day, and your testimony here today is right along there with it. So God bless you, and thank you for being here, and thank all of you for being here. And if there's anything that me, my staff, the committee can do, please keep us apprised. Any suggestions, ideas, we will be honored and glad to work with you. I yield back.
The gentleman yields back. It's now a pleasure to recognize the gentlewoman from Delaware, Ms. Blunt Rochester, for her 5 minutes of questioning.
Thank you, Madam Chairwoman, and thank you so much to the witnesses for your testimony. I especially want to acknowledge Representative Kelly for her leadership in this important issue. I held a town hall meeting in the past month over the recess, and a midwife stood up and shared her perspective on the role that she plays. And one of the things that she focused on was the social determinants of health, particularly in maternal mortality. And she said that she was caring for a soon-to-be mother, many of which are told, go out and get some exercise, but they don't feel safe walking around their neighborhoods, or who are being told to eat nutritious diets, but don't live within blocks of a grocery store selling fresh fruits and vegetables. And as we transition our health system, I think it's critical that we think about the social determinants of health and all those things that surround it. And so my first question is to Dr. Harris. Can you talk about the social determinants of health and how we can address this challenge of maternal mortality by dealing with the social determinants of health?
Thank you, and I can say that the AMA is very committed to addressing these issues, because if you look at that circle of care and you look at the fact that maybe health outcomes are impacted, and we know they are impacted some by physicians and hospitals, but we see a huge impact related to the social determinants of health, transportation, housing, whether or not you have a job. You mentioned whether or not you live in a food desert, and I know now, and my colleagues can talk about whether or not you live in a maternity care desert. So those are all pieces that we plan to focus on as we build out the work of our Center for Health Equity. But I will say we have current policies that raise the importance of social determinants of health. So wherever we go, I mentioned that in my own work, that it is not enough for us to say to exercise. Physicians should say that, but we have to make sure there are equitable opportunities for exercise to access healthy, nutritious foods. So that work will be included in the work of our Center for Health Equity.
Thank you. This question is for the panel, and it is one that has plagued me for a long time. And Ms. Irving, first of all, thank you so much for sharing your testimony and for sharing your daughter's story. And it is at the heart of my question. I don't understand why. I can talk about the social determinants of health and understand that there's a disconnect sometimes between access to health care or the kind of health care, but your daughter, smart, understood health. And I watched a Jon Stewart piece last night about maternal mortality, which is interesting. And he said that they showed a clip of a father, an African-American man, who said his wife died because he was afraid to be perceived as the angry black man if he spoke up for her. And so I'm curious, can you explain to me, for those African-American women that are experiencing this, and it's not an issue of access to health care, education, a doctor, can someone help me understand, what is it? What's going on?
I'll start off and then turn it over, but I had the same issue, and I suffer now from regret that I wasn't that angry black woman. And I think my daughter kept me from doing that, because she would say, Mom, just calm down, just let them handle it, it's gonna be okay. But it wasn't okay. And I wish now that I have stood up and said, look, you're gonna do something right now. But I think it might have had the negative effect, because then I would have pushed them away, and it would have, I can't see how it would have turned out any worse than it did. But that's what a lot of black women or black men face when you're coming in, because you are looked at as a threat. And then if you start getting loud, the next thing you know, you could be put out of the hospital because you're not communicating in a way that is acceptable.
Right, thank you. Doctor?
So that is an important part. I would say that is the other end of folks examining their own implicit biases. And I'll just take, I have not had a child, but I've often been the only African-American woman in a room. And I think people of color, particularly African-American women, because there are issues around discrimination based on gender and race, end up self-editing sometimes and being extra careful so that we are not the angry black woman or the angry black man. And I think as we have this conversation, we have to talk about that more. It only comes, I think, with some practice and some experience and, frankly, some privilege that you feel more comfortable raising issues. And that should not be the case.
You're right.
And so I will say that was part of our discussion, will be a part of our discussion at the AMA, but it really needs to be a part of this society's discussion. To look at, I think, the biases and the racism and discrimination in all contexts.
I know I'm out of time, and it's just something that has plagued me. I know people like Serena Williams, Beyonce, have gone through this, and so it is not even, it's beyond privilege. Thank you so much for having this hearing, and I will send questions in writing. Thank you.
The gentlewoman yields back, and you asked a heavy question, but a necessary one. It's a pleasure to recognize the gentlewoman from Indiana, Ms. Brooks, for her 5 minutes of questioning.
Thank you so much, Madam Chairwoman, and I also want to thank the ranking member because this is something that we have been focused on for a couple of Congresses, and we must do more. We rarely in this body, I think, have an opportunity like we have now to educate those medical providers of the future. And one thing that you mentioned, Ms. Irving, and I want to thank you so much for sharing your horrible, very, very sad story, but the power of your testimony, the power of your written testimony, which I read this morning and was quite moved this morning, even before you spoke. You mentioned something that I don't think that we've talked about enough. Although Dr. Burgess mentioned it in his medical training, he had a doctor who talked about care about caring. And you mentioned med schools. And I think the hearing we had last Congress and the hearing we're having this Congress, from all of you, the incredible professionals here that are studying it, that are working on it, that are trying to improve, Indiana has the third highest rate of maternal mortality. Now, yes, we just instituted that review committee. Luckily, our new head, or fairly new head of State Department of Health is an OBGYN, and this is a top priority, Dr. Christina Box, top priority now for our state. But we've got to start earlier. The review committees are after the fact. We've got to study the data. We have to collect the data to understand the problem. But what would you all like to see our med schools do, our nursing programs do? We haven't really talked, that's one aspect we haven't really talked about. Maybe starting with you, Ms. Serving.
I think the training that we have talked about before, as far as the implicit bias training, et cetera, is good to start early. They must recognize that every patient should be treated as an individual. Even though we have standards of care, you look at the patient as a whole. And I haven't been to medical school, so I don't know what the training is, but you have to have that. It could be my mother, it could be my wife, it could be my daughter, and look at each patient through those lenses and work on it from that point.
Thank you. Dr. Harris, how do we take what Ms. Serving is hoping and praying that, folks like you all implement?
I think that's critical, and the AMA 5 years ago looked at the issue of training the next generation of physicians. And we awarded 11 $1 million grants and have since then developed a consortium of other medical schools that can share best practices. And I will say a couple of those medical schools are specifically focused from our grant, although they were already working in these areas, on two issues that have been raised. One is the social determinants of health. So we have medical students now getting trained and understanding and appreciation the importance of social determinants of health. And we have a couple of other medical schools that are talking about health disparities, making sure that the future workforce is a diverse workforce, so that the faces of our physicians match the faces of our patients. And then, of course, from those learnings, we are spreading that out to the consortium of medical schools, and then hopefully that will be spread out to the entire medical school community. So we are committed and do agree that we need to raise these issues early in training of physicians.
Dr. Nelson, I want to commend Parkland, and thank you, Dr. Harris. Has the med school community reached out, and are they studying your model in Parkland, and how do we do a better job getting, because it's not just doctors, it's nurses. I'm sure there were many nurses that didn't listen to your daughter's needs, not just doctors, nurses, others. how about the medical training? I don't just mean med schools.
Correct, and that's what I was actually going to build upon. So I am a faculty at the University of Texas Southwestern Medical Center, and we're one of the largest obstetrics and gynecology programs in the country. We have 72 residents in our current existing program. And part of our responsibility is to talk about and begin the training that you've heard here. It also extends to the training that we have within our nurse midwives, our advanced practice providers with nurse practitioners, and nursing students that we're responsible for training the next generation. And this is the part that becomes really difficult, is translating the importance and advocacy that we're hearing that we need to share and fighting for our patients, and hearing their voice is something that's our responsibility to carry forward.
Well, thank you all. My time is up, but I certainly hope that our med schools take the opportunity to actually listen to your testimony, to read it and to listen to it. I think it would be incredibly instructive. With that, I yield back.
The gentlewoman yields back. I now would like to recognize the gentleman from Maryland, Mr. Sarbanes, for his 5 minutes of questioning.
Thank you, Madam Chair. I want to thank our witnesses for your testimony today. Extremely compelling, and in certain instances, obviously heart-wrenching. So thank you for being here. Ms. Ranji, I wanted to talk a little bit more about the situation that women can find themselves in when they have to make a switch to different coverage because of the expiration of Medicaid coverage. And we've heard from many of you, and it's well documented, that the current Medicaid pregnancy coverage only covers women for 60 days after they give birth. And then at that point, what happens can range from losing coverage completely, potentially being able to enroll through a marketplace plan on one of the exchanges, et cetera. Obviously, getting some coverage after that 60 days is better than having no coverage. But I think it's important to recognize that forcing women to change plans during what is a very, very critical time can also generate negative consequences. So I'd just like to ask you a few questions about that phenomenon, which is referred to in shorthand as churning. If a woman gains Medicaid coverage as a result of her pregnancy, what are the coverage options after that coverage ends 60 days postpartum? What is the range of things that could happen there?
Right, well, it really depends where you live. And this is when it comes to postpartum coverage, there is a lot more variation across the states for low-income women. And so, like you said, some women are able to continue on Medicaid. Some may be able to get subsidies to purchase private insurance. Some may be uninsured. But the phenomenon that you refer to, churning, certainly has an impact. We know that disruptions in coverage are relatively frequent for low-income women around the time of delivery. And we know that churning can negatively affect access to care. Things like it can result in delays in care, having to switch providers, identifying a new provider network, and down the road that can lead to delays in things like preventive services, like cancer screenings, et cetera. So churning is relatively common among this population when you have to switch plans.
I mean, in fact, that's exactly the moment in time when someone's condition might change in a way where if there was a continuous perspective, because the coverage was lasting for a longer duration, that change would be captured in terms of the care plan for that particular individual, but because there's a transition happening to a different coverage, potentially involving different providers, involving a different set of benefits as to what's covered and what's not covered, the system will miss the opportunity to identify the kind of care that should be delivered, and then you can end up having drastic consequences from that. Is that correct?
Well, and being able to stay with the same coverage plan can allow you to stay with the same provider and provide that continuity of care from a relationship that a woman may have formed with during the prenatal period, with the provider being able to continue with that provider or with that group of providers could streamline her access to follow up on conditions and obtain preventive services.
I would also imagine that it's going to be easier to deploy strategies for more sensitivity to the patient population. And we've heard testimony about the importance of that today. If the coverage situation is not one that's in flux, it's just better if you've got a longer period of time in which to deploy these strategies to get out in front of some of the biases, discriminatory practices, and other things that we've heard testimony about today. So clearly there's strong arguments in favor of extending the Medicaid coverage period substantially, and that's at the heart of a number of the proposals that we are hearing about today. Thank you all for your testimony. I appreciate it, and I yield back.
Gentleman yields back. It's a pleasure to recognize the gentleman from Montana, Mr. Gianforte.
Thank you, Madam Chair. Ms. Irving, I just want to say I'm sorry for the loss of your daughter, and I want to thank you for being here to tell your story. Unfortunately, Montana has a higher maternal death rate than the national average, and our state faces unique challenges in this space. Dr. Howell, in your testimony, you state that maternal deaths from substance use disorders and mental health are climbing. Unfortunately, methamphetamine use is an epidemic in Montana. How does drug addiction impact maternal deaths, and what changes can we make to help mothers who are facing a drug addiction?
So just as substance use disorders are growing across our country and we're having an opiate crisis, that also affects maternal deaths as well as from other areas. And although this is not my area of expertise, I'll just share that I think that the risk factors and some of the issues are lack of treatment centers for opiate abuse and also lack of access to opiate replacement therapies.
So our specific problem is methamphetamine.
So that is not my area of expertise, but I think some of the general things that we know about substance use disorder can be applied in the maternal health care setting, and that we don't recognize that there are other options and there are treatment alternatives and that there's not enough being done. I would defer also to my colleague if he has more.
Dr. Nelson?
So we have a robust perinatal intervention program that covers opioids as well as methamphetamine use. This requires intense multidisciplinary care. It involves case management, addiction medicine, obstetricians, and pediatricians. And it has implications related to the care of the mother during the pregnancy. It can also have implications to the baby at delivery as well.
Okay, thank you. Today is World Suicide Prevention Day, and unfortunately, Montana leads the nation in suicide, #1. We understand the impact that a lack of access to mental health services has on our communities. To ensure that people have access to these services they need in the face of this crisis, I recently introduced a bipartisan bill to designate 988 as the National Suicide Prevention Hotline. This is an essential resource for anyone facing mental health crisis. I look forward to working with my colleagues to get this bill through committee, and I hope it will be available to help mothers that we're discussing today. Dr. Howell, again, if we could, can you describe what's being done, especially in rural areas, to address the increase in maternal deaths from mental health complications such as postpartum depression?
So I'm not an expert on rural health care coming from New York City, but I can comment that I think that a lot of the things that you were hearing about, depression is a major issue for pregnant women and postpartum women. You've heard rates of around 15%. And so it's a major issue not only for breastfeeding, maternal infant bonding, but everything you can think about for both the mother, the child, and the family. And so we have to do a better job around mental health. Now, in rural areas, just like there are major access issues in cities around mental health, as you've heard, but there's also additional barriers. And so the use of telemedicine, the use of new techniques around cognitive behavioral therapy on internet platforms, sort of thinking outside of the box is the way that we have to move forward to sort of broaden our ability to reach patients from everywhere around the country.
And that's really essential, particularly in our rural communities. We're not going to have a specialist in every discipline in every community. Telehealth is one way to do it, so I appreciate your comments there. Dr. Harris, Montana has 7 federally recognized American Indian tribal governments. You mentioned in your testimony that CDC recently released a report that American Indian women are 2 to 3 times more likely to die from pregnancy related to causes than white women. Can you talk a little bit about the key drivers of this disparity in our Native American population?
So I would imagine that it's about access, it's about bias, all the issues that we've discussed today. We want to make sure that we appreciate all of the issues faced by those who are not of the same community. Again, that's why we stress the importance of a more diverse physician workforce, making sure that those in rural areas have access to healthcare. You mentioned telemedicine, making sure that everyone, again, has affordable, meaningful coverage. So I think all of those drivers are the same or similar. They won't be absolutely the same for Native American women as African American women. And I appreciate your point on methamphetamine being an issue in your state, and I think that's why certainly we need to do all that we can to address opioids, but I think there is an opportunity here to make sure we have an infrastructure for substance use disorders in general and not just regarding opioids.
Yeah, thank you, Doctor. And just in closing, Madam Chair, if I could, I want to echo the comments of Ranking Member Walden in his call for additional hearings, and I would just suggest that if we do that additional hearing, that we might include the Native American voice at the table, because the tribal communities are not represented here today, and possibly IHS, Indian Health Services, as well, as we continue to look at this issue.
Well, I think it's an excellent suggestion from the gentleman, and we have 2 members of Congress, women members of Congress, for the first time in the history of the Congress, that are Native Americans. Thank you. Now I'd like to recognize the gentleman from California, Mr. Cardenas, for his 5 minutes of questioning.
Thank you so much, Madam Chairwoman, and also I'd like to thank Ranking Member Burgess for having this important hearing on this very important and heartbreaking issue. I want to also thank all of the panelists for providing your expertise, especially Ms. Irving. You're someone who should have never had to learn so much about this issue and then to endure what you've had to endure. So thank you for coming in and enlightening us. Ms. Irving, I'd like to thank you for sharing with us today what you've been going through, and I know it's not about you, it's about making sure that we do better for the families and the women of today and tomorrow. So thank you for enlightening us. As a parent and a grandparent, I can only imagine the pain that you've gone through, and I certainly agree with those who have been calling you very brave. But I'd also like to point out that I truly do believe that you are an embodiment of what it is to have faith. And by being here today, you're putting that faith into action. And I believe that it is incumbent upon us on this side of the room to act responsibly and to do whatever we can to make sure that we pay heed to your advice and the wisdom of all of you so that we can actually take action swiftly and accurately so that less pain is endured by families going forward. I do have a question for you. Could you please describe for us what high-quality, fair, and respectful postpartum care for your daughter could or should have been, should she still be with us?
I think for the first time, what should have happened is she should have been able to see her doctor within a week after giving birth. Just like the baby went in 2 or 3 days after birth, there should be a mandatory 1 week. Let's come in, let's check you out, let's see how you're doing. She should have been able to call up a doctor or go in and see the doctor right there. Instead, what she had was she saw a nurse practitioner a couple of times. And that nurse practitioner left and said she came back to see the doctor, but the doctor never showed up at all. And so I would think that the doctors would follow their patients and make sure that they see the patient and make sure that their symptoms or concerns are addressed right then and there.
Thank you. What you just described is proper standards of care in the moment, case by case, not just theoretically. So thank you so much. Dr. Howell, We've heard about some of the systematic barriers to care that Black women face, and we know that Hispanic women face many of the same obstacles, as do Native Americans, et cetera. Yet reporting on the rates of maternal mortality for Hispanic women has been inconsistent, and it is difficult to find clarity on what it is telling us. Can you speak to this issue and what the potential consequences to this lack of data might be?
Yes, so a perfect example is that the national statistics do not suggest that Latina women have an elevated rate. Our pregnancy mortality review done in New York City revealed, when I said that there were 8 to 12 times higher for Black women, for Latina women it was 3 times higher. And it shows you that when you get more granular data and when you invest in maternal mortality reviews that actually collect data from multiple sources, you can get better data on race and ethnicity, you can get the causes, and that allows us to actually see a true story. Without the data, you don't know, and that's what happens when you have a vital statistics system that doesn't collect this stuff in a good way. That's why I think it was underreported.
Okay, thank you. One of the things that I'd like to personally comment on, that I want to thank all the women who are here in this committee room, and also the men, but the women vastly outnumber the men who are guests and experts apprising this important committee on this very, very critical issue. And I personally want to add to that, that I believe that when this side of the room looks more like that side of the room, I think that especially when it comes to issues facing women and families, we're going to see much quicker, much more accurate results out of what happens in the decision-making of this elected body. I'm not casting aspersions on us men or what have you, but what I'm saying is when there are women in the room, you enlighten us in a way that you think of things and approach in a way that I just can't. And I just want to thank you for doing that at every opportunity, and certainly today. Thank you very much. I yield back.
Thank the gentleman for, most especially for those comments, as well as the others. It's a pleasure to recognize the gentleman from Georgia, Mr. Carter, for his 5 minutes of questions.
Thank you, Madam Chair, and I want to thank each and every one of you for being here today. This is an extremely important subject, and especially want to thank you, Ms. Irving, for being here. Yours is quite a compelling story, and we just cannot say enough about your courage and your work, and we thank you very much for that. Ladies and gentlemen, I'm from the state of Georgia. This is obviously maternal mortality is a national problem. There's no question about that, but in the state of Georgia, it is a serious problem. In fact, we have the unenviable position of being the #1 state in the nation in maternal mortality, and for what reason we can't figure out. But that's what really is driving us to try to do something about this. And I've been doing it. I've been doing it in my district. I've held many roundtable discussions with different groups about why is this and how can we address this situation and how can we make things better, because we all want to make it better. Regardless of which side of the aisle you're on, you want to make it better. This is not a Republican, this is not a Democratic issue. It does not discriminate against anyone, and we have to work toward a solution. And I have to tell you that I'm really proud. The last session that Representative Jamie Herrera Butler, her bill, Preventing Maternal Deaths Act, passed, and that's good. It was signed into law. We need more bills like that, and I'm really proud of that. I will have to tell you that I'm a little bit disappointed that we don't have some Republican bills that we're talking about here. In fact, we don't even have much Republican input in these bills, and I hope that that's going to change for a couple of reasons. First of all, we've been out in our district for the past 5 weeks, and I have been proudly proclaiming that not only do I serve on the oldest and the most diverse, and as far as subject matter is concerned, committee in Congress, but also the most bipartisan committee, and I consider it to be the most bipartisan committee, so I am a little disappointed. I have to express that to the chairperson, that we don't have more Republican bills. Now, having said that, I will tell you that I do have a bill that I'm working on with Representative Catherine Clark of Massachusetts that has to do with Medicaid. It's a Medicaid demonstration project that tests how we might be able to enhance access to care by better utilizing birth centers. All throughout our testimony today, what we've heard about is access to health care. That is extremely important in the solution to this problem. We all understand that. And birth centers, I think, are not being utilized to the point that they could be. And I hope that it's something, and I thank Ms. Clark for working with me on this, and it's something that I want to work with her on. Ms. Ranji, I will ask you first. Again, one of the things that we've heard during this testimony has been access to health care, and I would just ask you, is there a better place or a place for better use of birth centers that we could possibly use them in a potential solution or partial solution to this national health problem?
Well, thank you for the question. Just as Medicaid policies vary between states, it's a similar situation with birth centers. And so while birth centers themselves are not my area of expertise, I know that the availability and the certification and the licensing procedures and practices vary between the states. And so I could certainly see that there would be room for growth and of presence in birth centers and coverage under Medicaid. But again, the availability and access, those vary a lot between localities. And the financing policies would then have to be worked out with it.
Right,
state
right.
level.
Well, and one thing that I will inform you about is that I represent South Georgia. You know, there are two Georgias. There's Atlanta and there's everywhere else, and I'm in everywhere else. So birthing centers are extremely important for us, and particularly in the rural areas. So that's why I look at that, and I'm excited about this bipartisan bill that Representative Clark and I are working on. Dr. Nelson, I want to ask you, currently I'm the only pharmacist serving in Congress, so I have a very interest in opioid epidemic and a very strong interest in how it's impacting maternal health. And I just wanted to ask you, could you very quickly help us to understand when you have a mother who is going through an opioid addiction, how they are handled and treated during the pregnancy?
So the problem of opioids is also a major crisis for this country. In 2017 alone at Parkland, we delivered 69 women with opioid disorder. In 2018, I personally toured Dr. Gerard and Dr. Adams, the Assistant Secretary for Health and the U.S. Surgeon General, through Parkland Hospital to see our program. And our program is comprehensive, and the challenges are both related to the maternal care, the risk to mom, but also the neonatal opioid withdrawal syndrome risk to the baby. And that is a chronic, life-changing opportunity for us to have resources provided for a pregnant mother and her unborn child.
Just real quickly, just how do you get over the stigma, or not stigma, but the obstacle of a mother who is addicted that doesn't want that to be known, so she doesn't reach out for care? I know that's got to be a problem and something we've got to address as well.
I agree that stigma is important. Our service as physicians is to be a healthcare home for those patients and to provide them access. And that's a complex issue related to interfacing the legality of some of those circumstances. But our first and foremost effort should be providing access to care to those women and getting them resources to potentially even get better.
Great. Again, thank you all for being here. So this is a most important subject, especially for the state of Georgia and for our country. Thank you, and I yield back.
The gentleman yields back. It's a pleasure to recognize Mr. Engel from New York, who is the author of the Quality Care for Moms and Babies Act. Thank you for your solid work, Mr. Engel, and you're recognized for 5 minutes of questioning.
Thank you, Madam Chair, and thank you for holding this very, very important hearing. And thank you to all the panelists. Thank you so much. We appreciate everything that you've done. Ms. Irving, I want to single you out because what you're doing today takes an enormous amount of courage. And so God bless you, and know that we support you, and what you're doing today will save the lives of countless other people tomorrow. So thank you for having the courage. I want to thank the chairwoman and the chairman, Pallone, for holding today's subcommittee hearing on the nation's maternal mortality crisis, and which includes my bipartisan, as the chairman said, bicameral legislation, the Quality Care for Moms and Babies Act. The bill would bring together diverse stakeholders to develop care quality benchmarks for women and children, as well as to also find existing and new quality collaboratives. Quality collaboratives are on the front lines in the effort to end this crisis. The New York State Quality Collaborative has developed resources to address the leading causes of maternal deaths in New York, which include hypertension and hemorrhaging. These resources were distributed to over 126 birthing hospitals in New York. So I urge members on both sides of the aisle to support this common sense bipartisan legislation. I would also like to ask for unanimous consent to submit a letter of support from 8 organizations, including March of Dimes, the American College of Obstetricians Gynecologists, in support of the Quality Care for Moms and Babies Act. Dr. Howell, it's always good to see more New Yorkers in Washington. I get lonely over here, so please come back. And thank you for the great work that you do and that Mount Sinai does as well. Mount Sinai, of course, is very well known in New York and very well respected. So I want to personally thank you, Dr. Howell, for your service on the New York State Task Force of Maternal Mortality. And it's my understanding that the task force issued a report this past March in which it recommended expanding the New York State Perinatal Quality Collaborative. And as you know, as you mentioned, which I appreciate you mentioning it, I'm sponsoring the Quality Care for Moms and Babies Act with my friend Congressman Steve Stivers. So it's a bipartisan bill. Our legislation authorizes funding for existing and new perinatal quality collaboratives. Let me ask you, Dr. Howell, can you again share, I think it's worth repeating, why developing and sustaining perinatal quality collaboratives is an important tool for addressing racial and ethnic disparities in maternal health outcomes?
It's a very important tool for us to use across the United States as well as in New York because it allows us to have partnerships with physicians and nurses, with departments of health, hospitals, and health systems to target specific processes based on the evidence that we can target together to improve. And we've done it in a number of different situations, not only in terms of the bundles that you've heard about, but in terms of trying to lower our cesarean section rates, in terms of our elective delivery rates. We've done it on the NICU side. And so it's these groups that can take the shared learning and utilize that to help make improvements in hospitals. And your bill supports that, and I think it's a really wonderful and important part of this story that we need to advocate for.
Well, thank you, and I have high hopes that we'll pass the bill and pass it on the floor and hopefully get it passed in the other body and have the president sign it into law. So thank you for everything you're doing. Dr. Harris, let me ask you, in your written testimony, you note that the quality of maternal care can vary greatly by provider and facility, given that public health programs cover most births in the U.S., with Medicaid alone covering 43% of them. I believe, obviously, these programs are uniquely situated to improve maternal health. To that end, the Quality Care for Moms and Babies Act would direct the development of a core set of maternal and infant health performance measures for Medicaid and CHIP that promote best practices. So let me ask you, Dr. Harris, how would the creation of this measure core set affect the quality of care and reduce maternal morbidity and mortality, especially for women of color?
Congressman Ingle, if you don't mind, I'd like to let Dr. Howell talk about the specifics of that, of the core metrics and how they would help. But from sort of the 30,000-foot view, it's very important to have the data. Data that then informs, and that's again why the AMA is very supportive of these review committees. You've heard a lot today, but there is no sort of one-size-fits-all solution, and patients are unique. And as Dr. Howell mentioned earlier, California has done a great job of reducing mortality, but not African-American women. So we still need to look at the data and why overall mortality decreased, but not African-American women. So I think the opportunity there is to get that data, get the data specifically for African-American women. And then once we get the data, it's important to have funding to implement what we find in the data. So I would say that from a 100,000-foot view, and let Dr. Howell talk about specific measures that should be included to improve those disparities.
Well, thank you. If the chairwoman will indulge, we have Dr. Howell.
So I think it's incredibly important that we develop quality measures in maternal health care that are both patient-centered and address disparities. You know, we've done work showing that hospital performance on primary low-risk cesarean or hospital performance on elective delivery is not correlated with hospital performance on severe maternal morbidity. So the current group of quality measures don't really provide information to mothers about that different facilities in terms of safety, and they weren't correlated either with neonatal morbidity at term. We need better quality measures that can serve and we can give to the public so that they can better understand what's going on. So your bill that advocates for quality measure development, I think, is really instrumental and a very important piece. And having quality measures also target disparities and address disparities is another piece, because previous data shows that the quality measures in obstetrics really are not doing that either.
Thank you, Madam Chair, for your indulgence, and thank you for all the great work you're doing.
Thank you for your work, Mr. Engel, and this sounds like a resounding, we recognize endorsements, don't we, when they occur? I think I just heard one. I now would like to recognize the gentleman from Illinois, Mr. Rush, who I'm really pleased to be joining him in his congressional district in a handful of weeks, where he is conducting a field hearing on this very issue, and you are now recognized for 5 minutes for your questions.
I want to thank you, Madam Chair, and I certainly want to applaud you for holding this critically important hearing. Ms. Irving, I feel you. I understand some of what you're going through. I'm reminded just this very day that some 10 years ago, this very same subcommittee, had a hearing on postpartum depression. I had introduced a bill entitled the Melanie Block-Stokes Postpartum Depression Act of 2007, and her mother, Melanie Block-Stokes' mother, Miss Carol Blocker, sat at the very same table that you're sitting at some 10 years ago. Melanie was one of my constituents who had been seeing a series of doctors postpartum, and none of them diagnosed the depression that she was going through. And she ultimately, on a bright Saturday morning, spring Saturday morning, went up to a hotel in Chicago, on the near north side of Chicago, and leaped to her death from the 10th floor. And the cause of it was postpartum depression. So, here you are, another mother in a line of mothers who are coming to this Congress asking and pleading and bringing your pain to our presence, to this table, asking us to help. And I want you to know that some of us are determined to provide the help that you are seeking and other mothers are seeking. My bill the language of my bill was included in the ACA Act, in the Obamacare, and I was very pleased with that, but we have such a long, long way to go in order to deal with this. So I applaud you, and I commensurate with you, and I just, your pain is a pain that generations will remember and will bear until we are able to solve this problem of maternal mortality. I want to move to a question, if I got a few moments here, and I want to ask Dr. Roger. Dr. Roger, I'm curious about doulas and the effect on the healthcare system as it relates to doulas. And can you explain to us why you think that doulas can improve health outcomes? And also, can you address what are some of the cultural and economic barriers to presenting a nationwide system that would include doulas?
Well, the research shows that women and moms have expressed, in many surveys, have expressed interest in having doula care, more support during the prenatal, labor and delivery, and postpartum periods. There is, some sense, we talked earlier, the panel was talking about the ability to be able to, sometimes for patients being able to challenge providers or ask for what they need. And there's some research showing that women have said that maybe if they had more support, for example, with assistance from a doula, that might be part of expanding her ability to be able to recognize and sort of understand what her options are. Currently under Medicaid, only 2 states, as far as I know, Oregon and Minnesota, include coverage for doulas, but there are some other states that have certainly been considering it, and New York is one that has a pilot program going in certain parts of the state where they're also considering, at least they're doing for some women, expansion of coverage for doulas.
Mm-hmm. So do you know of any, what are some of the barriers that you see in terms of, that we may face in terms of implementing or creating a doula care system?
Right. Well, some of the barriers include sort of administrative and procedural barriers. Right now, Medicaid reimburses licensed medical practitioners, and the sort of doula training standards and doula certification and licensing is still an area that's in work. It's not an area that I have focused on, but there is a lot of published research out there that I'd certainly also be able to share with you if that's of interest.
Well, thank you, Madam Chair. You're back.
Thank the gentleman for his work on this issue, and I look forward to the hearing in your district. Now, I'd like to recognize Ms. Schakowsky of Illinois, who's a member of our full committee and is waving on to the Health Subcommittee today, where she served for many years. So you're recognized for your 5 minutes of questions.
Thank you so much, Madam Chair, for allowing me to wave on to today's hearing, and it's such an important one. I want to thank all the witnesses, and I want to give a special thank you to my friend and colleague from Illinois, Robin Kelly, who has been such a champion of this issue for our state. Illinois has been one of the most extreme pregnancy-related death disparities in the nation. According to data from our Department of Public Health, Black women are 6 times more likely to die of pregnancy-related conditions as white women. It's just totally unacceptable. And I want to say a really special thank you to Mrs. Irving, and I am so grateful that you have shared your daughter, Shalon's story with us today. And I just want to add, when I read the article that was given to us, that this is a 3rd child and the last child that you have also buried. So I'm so sorry for that. I firmly believe the words of your testimony, that this disparity, quote, has to do with the appalling way Black women are or aren't attended to or listened to, unquote, and I am fully supportive of extending Medicaid coverage for the postpartum care up to from 60 days to 1 year, as the bill that we're considering today proposes, and though that will make a transformative change, that's certainly not enough. Ms. Irving, I wanted to ask you a question. Here you have such an educated daughter in the healthcare field. She's a doctor herself. What did the physicians tell her as she continued to suffer after the birth of her daughter that somehow indicated that they must not have been hearing her?
Every time she went to the doctor's office and there were probably at least 3 times I know of in 1 week. Each time it was a dismissive, you just had a baby, give it time, you'll feel better.
Did they do any of the tests that would have indicated what the problems were?
On the last day that she went, which was the 24th, 5 hours before she collapsed, she went in and they gave her a test for preeclampsia. But since she didn't have any blurriness of vision, they said, well, we can rule that out. And they gave her a test for blood clotting. She said, I've had blood clots. I know what they feel like. This is not a blood clot. And of course, it wasn't a blood clot. But her blood pressure was still off the roof. I think if I'm correct, it was 174 over 119. And she was sent home. And 5 hours later, she collapsed.
Well, you had also said in your testimony that essentially that no one is really immune regardless of education, et cetera, and that the issue of racial disparities is certainly a huge problem. I wanted to ask Dr. Howell a question. I'm interested in the idea of holding hospitals accountable for maternal care, maternity care through a value-based care model. Do you believe that bundled payments for an entire episode of maternal care could give health systems more incentives and greater control to improve the pregnancy-related outcomes from beginning to end with regard to racial disparities in particular?
I think we need more work on alternative payment models to think about maternity care and incentivize clinicians and hospitals correctly. I do worry about unintended consequences, specifically that certain hospitals will be penalized if we don't do this right, in terms of the fact that they have the highest risk patients and we're not recognizing that. So I think there is a lot of work to be done in this space. I don't have the perfect solution yet because I want to make sure that we think about those unintended consequences as we move forward.
So do you think bundled payments may be one thing that at least should be explored so that from prenatal care through the full year, maybe even issues like postpartum depression, be considered in a bundle of payments?
I absolutely think that they should be explored. I think that the measures that they would be accountable for would need to be partnered with new quality measures that are really well developed, and so that we have the right things. Some of those measures would also be targeting disparities. So if you measured the success based on those quality metrics that look at patient-centeredness and disparities, might be a promising avenue. But again, always remembering that we can't penalize those hospitals that take care of the sickest patients. So we have to make sure that we are accounting for that in our models.
We also want to make sure diversity in the workforce is there so that everyone is represented at every level of care. Thank you so much. And again, Ms. Irving, thank you so very much. I yield back.
The gentlewoman yields back. I want to, on behalf of every member of the subcommittee, I want to thank each witness. Ms. Irving, there really aren't words. Your source of inspiration to us to move ahead in your daughter's name, in your name, in your granddaughter's name. And I think that as she's watching and listening from heaven, you can hear the bravos from there. Thank you, thank you. You really have, you've touched all of us, and we're not going to rest until we have solid legislation that addresses this, and that this statistic in the United States of America piercing the conscience of our country. And I think it's a combination of things, women being undervalued, women not being listened to. In the history of humankind, no man has given birth to a child. And so I remember the doctor saying to me, well, they're the blues, but they'll go away. So we have a lot of work to do. Thank you. Thank you to you, Dr. Harris, Dr. Howell, Dr. Nelson, Ms. Ranji. This has been an outstanding hearing.
Madam Chair, if
yes.
I just could for 10 seconds.
Sure.
Ms. Irving.
I'm not a strict
I
chair,
just
as
was,
you can
I
tell.
was just looking at some notes. Melanie was also in the health care area. She was a pharmaceutical sales manager. So she was very aware of health issues, worked with doctors. Her husband was a physician. And she had a daughter, the only child, and her daughter's name was Summer. So your granddaughter's name is Salil, and so there's so many similarities there. I just wanted to note that for the record.
Okay, I'd like to remind members that pursuant to committee rules, they have 10 business days to submit additional questions for the record to be answered by the witnesses, and I know that you will all cooperate, give straightforward, succinct answers, okay? And I ask each witness to do so promptly to any questions that you may receive. I now want to ask unanimous consent to enter into the record the following: a statement from the March of Dimes, a statement from the American College of Obstetricians and Gynecologists, a statement from the American Hospital Association, a statement from America's Health Insurance Plans, a report from the Center for American Progress on Racial Disparities in Maternal Mortality, a coalition letter from the American College of Nurse Midwives et al., a statement from the Premier Healthcare Alliance, a statement from the Gauss Surgical, a report from Premier Incorporated on maternal health trends, a report from ProPublica and NPR on maternal mortality. So I ask for your unanimous vote. So ordered. And this will conclude our hearing today. The subcommittee is adjourned.